and both our eminent panelists have joined. So it's such a wonderful experience to have both the panelists joining at the same time. So good evening from India, and good evening, good afternoon, and good morning to everyone who is joining from different parts of the world. So far, 135 participants have joined, and the number is slowly increasing. But I'm very sure it will cross 300. It may go up to 500. We have a limit of 500, the seat limit. So usually it reaches 500, 400. So it's good to have people and from all parts of the world. The charts will be visible now. So thank you, and we shall start with the session right away. Okay. So Faisal, please start. Thank you.
Good evening, good afternoon, and good morning to everyone who are joining from all over the world. So a very warm welcome to our session 9 of the Global Advanced Certification Program on Strategic Research Collaboration and Communication for Emerging Researchers and the International Workshop Series, proudly organized by the Global Consortium of Global Health Actors, Leaders, and Thinkers, the Global Health Forum, the Global Brain and Mental Health Forum, in collaboration with local delivery partners, Bangladesh Institute of Innovative Health Research. Today marks our session 9 of the International Workshop and Panel Discussion Series, which features eminent speakers from around the world each weekend. So far, we have had a group of preeminent and renowned speakers from top academic institutions and top global organizations in Africa, Australia, India, Malaysia, Singapore, the UK, and the USA. We are thrilled to present two high-level panel discussions today featuring eminent scholars, researchers, and the global health leaders who are actively shaping policy, research, and clinical care across neurological, mental health, and aging-related domains. These sessions continue our vision of enabling future researchers to not just learn, but to lead global health change through evidence, ethics, and engagement. Once again, we are joined by our respected moderator and host, Professor Maheshwar Satpathy, CEO of Global Alt and Director at COE ECCPHP, who will guide us through these impactful discussions. So our organizers of this session are the lead organizer of this program, the Global Consortium of Global Health Actors, Leaders, and Thinkers. Global Alt operates under the Global Health Leadership by Global South Initiative, a flagship program of the Global Health Forum. Since January 2025, the Global Consortium brings together global health experts, researchers, practitioners, and policymakers, especially from developing and underrepresented regions, to collaborate on transformative research that drives equity and systemic change in health. As of today, the Global Consortium is the largest dedicated professional consortium of global health, with more than 2,000 leaders from 170 plus countries who have applied to be members through a rigorous process of member selection and full documentation of members' credentials. Our vision is reimagining global health leadership by the Global South, decolonizing global health. We are the global alternative. The Global Health Forum, elevating voices, reimagining global health, building equitable futures for all. Since 2018, the Global Health Forum is a dynamic international platform committed to transforming global health through inclusive dialogue, critical research, and ethical collaboration. As the parent institution contributing to the Global Consortium of Global Health ALT, GHF serves as a bridge between academia, policy, practice, and communities, especially those from low and middle income countries and underrepresented regions. GHF envisions a future where global health is decolonized, democratic, and driven by the lived experiences of those at the margins. We create space for cross-disciplinary exchange and nurture the next generation of global health leaders through strategic training programs, public health forums, and capacity building initiatives that cut across the geographic borders, cultural and social milieu, and disciplinary boundaries. The Global Brain and Mental Health Forum Reimagining Mental Health Leadership for a Resilient and Equitable World. Since 2020, GBMHF is a collaborative interdisciplinary platform dedicated to advancing brain health and mental well-being through research, policy advocacy, and international knowledge exchange, founded as part of the broader vision of the Global Health Forum and to complement the mission and objectives of the Global Alt. GBMHF aims to unite researchers, practitioners, policymakers, and people with mental health issues, as well as the lived experience advocates across the globe, particularly from the Global South. We focus on building capacity in neuropsychiatric research, destigmatizing mental illness, and promoting culturally competent mental health systems that are equitable, accessible, and sustainable for all. Through academic programs, high-level dialogues, and grassroots initiatives, the forum champions a holistic, intersectional, and inclusive approach to mental health. Bangladesh Institute of Innovative Health Research is a non-profit, student-led research organization that promotes research culture among students and early career researchers. Nearly 40 students contribute as research assistants and over 10 serve as a uh, core managerial roles. BIHR actively conducts public health research and regularly organizes training, workshops, and seminars to build capacity among emerging scholars since 2023. So some ground rules for our session participants: please remain muted during the session unless you are invited to speak, and use the chat box and Q&A to share your any questions or any reflections. Attendance will be tracked from start to end, and also a attendance form will be shared during the session, which are mandatory for certifications. Maintain a respectful and inclusive environment throughout. Chat box will be monitored regularly. Any unnecessary, repetitive, disrespectful, unprofessional, and hateful comment in the chat box or Q&A targeted towards anyone will be deleted, and such persons will be removed from the session. So our panel discussion 1 is neurological disorders and genetics research in India, muscular dystrophies, genetic counseling, and need for clinical guidelines, developments, and national health investments. We are honored to welcome Dr. B.R. Lakshmi, Founder Director Molecular Diagnostic, Counseling, Care and Research Center, Tamil Nadu, India, and PhD, IIT Madras. Hosted and moderated by Professor Maheshwar Satpathy, is a world-renowned leader in One Health, global health, planetary health, brain and mental health. He is a much sought after expert in epidemiology, health emergencies, and implementation science and health innovation using the power of emerging and futuristic technologies such as AI, ML, LLM, and generative AI, and geospatial information system science and technologies, and remote sensing. He builds on his core areas of expertise in cognitive and computational neuroscience, psychology, and global health to benefit humanity. Professor Satpathy has a humble H-index of 79 and cumulative citations over 156,000 plus. He has published extensively 285 plus peer-reviewed scientific articles and book chapters in journals of global repute, notably in Nature, Science, The Lancet, NEJM, JAMA, and others, and also has offered keynotes and invited talks at more than 200 top international conferences and global congresses in the past 20 years. He has an impressive all-metric score of 68,255, exemplifying the large-scale social impact driven by their work. Professor Satpathy is currently a research fellow, research professor at the Institute for Global Health and UCL Global Business School for Health of University College London, UK, and is also a substantive faculty member, professor at Utkal University, Bhubaneswar, India. He is the director and lead at the Center of Excellence in Environment, Climate Change, and Public Health Policy, COE ECC PHP, a joint initiative of the Government of India and Odisha since 2023. In the past, he has occupied prestigious positions as research scientist at UNSW Sydney, AIMS New Delhi, and consultant clinical psychology and assistant professor at Army Hospital RNR, New Delhi. He has held visiting researcherships, fellowships at the University of Oxford and Columbia University in the city of New York. He was a global health consultant, the Alalana School of Public Health, University of Toronto between 2020 to 2023. Professor Satpathy is an established scholar engaged with planetary health and well-being, global health, mental health, transdisciplinary gender and sexuality studies, and critical development studies focused on sexual and reproductive health and rights, and politics and ethics of social justice, and aim to nurture peace and harmony in the world. He has a successful track record of over 20 years in designing, delivering, and evaluating global and national public health programs. His multifaceted engagements in Asia Pacific, Africa, and Europe, and clinical practice in India have contributed to my well-grounded perspective and expertise. Professor Satpathy, may I invite you to introduce our distinguished panelist and begin this enlightening discussion, please.
Thank you so much, Faisal, for the wonderful and generous introduction of mine. It's wonderful to have Dr. P.R. Lakshmi as well as Professor Dilip just at the same time. It's quite a brilliant coincidence, but at the same time, it gives me lots of happiness and pleasure to welcome both of them. As per the format, we'll go ahead with welcoming Dr. P.R. Lakshmi as the first panelist. It's my utmost honor as well as pleasure to introduce Dr. B.R. Lakshmi. Dr. B.R. Lakshmi is founder and trustee and managing director of Molecular Diagnostics Counseling Care and Research Center, MDCRC, Coimbatore, Tamil Nadu, India, a holistic center in Coimbatore for research development. She is the founder member and vice president of Board of Genetic Counseling India, BGCI. She is also board of member of Asia Pacific Society of Human Genetics, and she has completed her PhD in biochemistry and genetics from IIT Madras. She has numerous publications and authorship in the area of rare disorders. She has her research interests include community genetics and creation of models to handle rare disorders, public health genomics, holistic approach towards genetic disorders, molecular diagnostics and genetic counseling, and her profile is extremely strong and robust. I've just jotted down a few points here because we don't have a lot of time today, unfortunately, because we have such eminent special experts, and we want to hear more from them. So I'll be very quick in introducing. Her career highlights include some of the very coveted awards. She has spearheaded the state-level project for identification and prevention of Duchenne and Duchenne muscular dystrophy in collaboration with the National Health Mission Tamil Nadu. She also directs and leads many research projects funded by the Ayush, ICMR, and SPC, Government of India. She has received the Yuva Shakti Award and Top 15 Women Scientist Award. She has also been honored with the prestigious Community Empowerment Award 2024 to raising public awareness of genetic disorder by the UAE Genetic Diseases Association, Dubai. So these are just very few small highlights of her career. I think the profile is extremely robust. It will take a lot of time for me to introduce, but I have the immense pleasure and honor to welcome her on the stage of Global Construction of Global Health. We are indeed very lucky to have both of you, Professor Dilip Chest and Dr. B.R. Lakshmi. So the format you already know, Dr. B.R. Lakshmi. So we shall start with your talk. We look forward to listening to you and be illuminated by your wonderful wisdom and experience. So the stage is all yours. Thank you.
Thank you. Good evening, all of you. Thank you so much, Dr. Satpathy, for the introduction. Nice to be along with you, Dr. Dilip Jeste, sharing the platform. Thank you so much. And all the wonderful participants on a Sunday evening to be here. I know how it is. And thank you. And thank you, Global Health Forum. This is my first interaction as such, and I feel privileged, honored, and I feel really good sharing the experience, which as the Global Health Forum introduction, we are bringing in the leaders for the country and the worldwide, the global forum. So I think the seniors as such sharing the experience is very crucial, and I'm very happy to share my last 15 to 20 years of experience, mainly in the area of genetic disorders. So are you able to see? Is it clear? So I head the foundation called MDCRC, which is in Tamil Nadu, India. And it's a registered charitable trust. And we work in the area. Is the screen clear? Hello?
Yes, yes, the screen is perfectly clear.
So the
Please.
focus has been on public health initiatives, mainly on neglected or rare disorders, and mainly for the underprivileged. So that has been the focus of MDCRC's work. And as I told you, we are in India because we have participants all over the globe. So more India, down south, Tamil Nadu, and in Coimbatore. And this is our center. And we have housed ourselves in a very efficient hospital called Royal Care Super Speciality Hospital, mainly because we need the clinical care again. And we being a not-for-profit foundation, standing alone, bringing in the clinician is a very tough job, which I'm going to explain when during the part of the whole session. And so we are housed in the 7th floor of this hospital. And ours is a journey on genetic services, mainly to say an NGO leading the way. This is something rare. You would have seen academics, or you would have seen universities or government bodies or private institutions, corporates doing it. But a not-for-profit foundation leading the way, I think we would be one of a very handful, or to say the one only, to the extent of which we have done in a very holistic way. So I'm very proud and happy to share our experience. And the topic which has been given today is on neurological disorder and genetic research in India, muscular dystrophies, genetic counseling, a need for clinical guideline development, and national health investment. And again, all of us who have assembled here understand the need as such. There's a huge need. And this particular area, mainly the genetic research as such, more in India, it's not really to the level because the country like India, with we have 28 states and the ethnicity and the biological diversity which we have in India. But so much could have, we are capable of doing so much more. But okay, we are wherever we are, and we necessarily, and I feel this forum is a wonderful space where we need to take it to the next level. And again, a very short introduction. Like, I'm not going to explain here as such what are neurological disorders, etc. But just a quick thing is neurological genetic disorders encompass a wide spectrum of conditions caused by mutations in genes. When you say genetic disorders, immediately we know there is some problem in the gene. Generally, we call it a mutation affecting. When you say neurological, it affects the brain, spinal cord, peripheral nerves, or the muscles. So it could be anything when we say it as, when we put it under the box of neurological. And these disorders can be inherited. When we say genetic, mostly is inherited, but we have lots of sporadic cases again. And they can be, when we say inheritance, again, it's a separate topic by itself. So it can be autosomal recessive, dominant, again, in a country where consanguineous marriages are so much. We know the inheritance patterns to autosomal recessive is quite huge, which needs to be addressed. And again, we have X-linked disorders like the ones I'm going to talk to you about, Duchenne. And again, these genetic disorders are broadly categorized based on their clinical manifestations, such as basically, when we say neurological genetic disorders, it can come under neurodegenerative or neuromuscular or neurodevelopmental. And again, to say like these disorders, so when you say neurodegenerative, you have Alzheimer's, ALS, Parkinson's, Huntington, Friedreich's ataxias. And again, if it's neuromuscular, you have a huge variety, more than 37 of neuromuscular disorders, of which I'm going to talk to you more about Duchenne muscular dystrophy, which is one among the 13 pediatric neuromuscular disorders. Becker is an allelic form of Duchenne, it's the same gene. And again, we have myotonic spinal muscular atrophy, you have CMT, you have types of limb girdle muscular dystrophy starting from 2A, 2B, 2C, and you have a whole range till Z. Then you have the FSHD, and then again you have the mitochondrial disorders, and then you have the neurodevelopmental disorders, then you have the channelopathies, lysosomal storage diseases, leukodystrophies, and other neurological disorders again. So these are all bundled up under the neurological again, but but today I'm going to talk to you more about muscular dystrophies, because if you're going to start talking about neurological disorders and its research in India, I would say research as such, nothing much is happening. Nothing very focused, very planned one, but there's a huge need. So I'm just going to take one example of muscular dystrophies, which are very common, and 30% of disabilities fall under muscular dystrophies. And they are, as I told you, there are varieties of it. So it depends on the type of muscle it affects. And here I'm going to concentrate on something called Duchenne muscular dystrophy. When you say Duchenne, it is a French name. It was in the 18th century, around 1878. The French scientist, the clinical scientist who found, sort of really named it and was able to explain more about it. And again, why does it happen? Here, it's because there are most of the muscular dystrophies happen because the protein which maintains, for example, in Duchenne, it is a dystrophin gene. And there's something which happens to the dystrophin gene. And all muscular dystrophy related genes are very huge, huge in size. So that's why there is sort of so much of research going on in the West, but still, till today, till this minute I'm talking to you, there is no cure for these disorders. So it has been very challenging. And name any muscular dystrophy, there's a protein behind it. And when you say protein, then you have to backtrack, Then you have the amino acid, you have the RNA, and then you have the DNA. So there is some issue mostly at the DNA level. It could be also in the RNA, but mostly at the DNA level. And this mutation causes the changes, and there's no protein. So here, dystrophin needs to be produced, but it's not produced because of the mutation, and you'll end up with the disease. And here again, the typical symptoms, and again, it's X-linked, which means it comes from the mother and it has got typical symptoms. I'll be talking to you about that. And so more to say, it is a very common platform. And you should remember that it is just an example I'm taking with Duchenne. Okay, you can apply it to any neurological disorder, because in your country, which is the most common and where you need to focus, but genetics and public health is something which needs prioritization in most of the developing countries. The focus needs to be there, and a framework for the integration of human genetics into public health practice to serve the community, because the community really needs it, but it is overlooked. And it is always diabetes or it's cancer, and that takes priority. These genetic disorders needs priority because the community, there again, more the rural ones, it's neglected in a huge way. And here the focus being neuromuscular disorders, mainly muscular dystrophy, which come under orphan disorders, more a country like India. It's not rare. I would say it is neglected or it is orphaned. Mainly, they are genetic in nature, contributing to close to 80% of locomotor disabilities. And again, when you talk about SDGs, because today lots of talks on SDGs, and when you work on such uh, common needs as such in neuromuscular, or to say in the neurological area again, or in genetic disorders or in rare disorders, the SDGs covered are number 3, which is good health and well-being, 5, gender equality, 10, contributes to reduce inequality, and again the final 16 for peaceful and inclusive society. The word inclusive is very important because the need is across. It's not a rich or a poor man's disorders. It comes across people from the rich to the poor, and we need to focus on these. And today, as I told you, I'm going to concentrate on Duchenne muscular dystrophy. It's a genetic disorder characterized by progressive muscle degeneration. It happens because of the alterations or lack of the protein called dystrophin. Now, mainly I'm saying this because you could take any of the disorders which you feel is important in your area or your country, and then you just need to think through in the way it is thought through, where you will arrive at a model. So the takeaway which I want after the talk is you should feel confident saying, yes, in my country, this is there, or in my region. And okay, if I go through this, this is a way we reach at the community level as a community genetics initiative. So try and understand more about the disorder. And again, this is with Duchenne. It is a huge gene. It has 79 exons. And what is the inheritance pattern? How does it come? Is it X-linked, or it is autosomal recessive or autosomal dominant? You need to understand that. And again, where is the onset? Does it happen early, late, or mid? So you need to understand that. And again, you need to understand what are the variations in it. For example, in Becker's, it's the same gene, but it is an allelic form, and it is much milder, and the onset is much later. So quite a few basic information about what you want to work needs to be understood with clarity. Again, as I told you, here it is autosomal recessive, which means it comes from the mother. The mother is a carrier, and it's on the X chromosome. So we women have two, so it generally doesn't affect women, but men have only one X, and the other sex chromosome is Y. So during every pregnancy, there's a 50% chance it can be a male or a female. All of us know it. There's a 50% chance the Y he takes from the father because he is male. But when it's the X, there's a chance that he takes a normal X or the affected X. So if he takes the affected X, he becomes, so this is the affected X. If he takes the affected X, he becomes an affected son. But if he takes a normal X and the normal Y from the father, he's an unaffected son. So in the same home, you can see an affected boy and an unaffected boy with Duchenne. Again, when it comes to girl, she can be a very normal girl, normal in the sense genetically where she doesn't harbor the dystrophin DMD gene mutation. So she takes a normal X from the father and the normal X from the mother. She's an unaffected girl. But if she takes the affected X from the mother, and of course a normal X from the father, now she resembles her mother, where she is a carrier. So she becomes a carrier daughter. Again, there is a 50% chance that she gives rise to sons with Duchenne and carriers who carry the affected dystrophin gene. So inheritance patterns becomes very important. So what does our center or MDCRC do is we offer 360-degree holistic service from molecular diagnostics. See, normal diagnostic, even a normal blood report, with glucose or cholesterol, people want counseling to understand what it is. But when you give a genetic report, then you need to counsel. I think it's ethically very important to counsel and give the report. And again, only when you understand the counseling and then you do the carrier testing, as the case might be, if it's X-linked, more the mother, if it's autosomal, both the father and the mother, then you can think through on prevention strategies. And then for the kid, the rehabilitation, multidisciplinary clinical care. And all of it is done at our center, all free of cost. And this has been going on for the last 15 years. And our journey, I'm not going to talk in detail, it has been long. More to say, nothing comes overnight. It needs to be worked on year on year. We grow. What next? What next? So diagnostic was there then. There was no counseling in 2005-6. There was no genetic counseling in India. Thought it's very important and started the basic. And it was 2014 that we could get the Board of Genetic Counseling. India established, where we joined hands. We're joining hands, as Dr. Satpathy rightly says, join hands when we really need to do something really important and which needs to happen. So it has been from 2005, year on year. And again, we did through all the Corona times again. And now we are in 2025, where it's a very holistic center which we have established, which I'm going to talk to you more. And again, keeping you in the platform of Duchenne. Duchenne, again, as I told you, it affects only males. And it's an X-link where women are carriers. Is there a cure? No cure. Again, put your disorder in the format. Just have at the back of the mind this. So what is a disorder? I'm sort of working, or it's more common in my country. How does it work? So just have it go behind your brain as such. And now we know there's no cure. Most of these disorders do not have a cure. And so we need to handle such lethal genetic disorders appropriately. And there you need to know the numbers. And I would bet most of the developing countries do not have the numbers. So that's very important. And we to give an example of Duchenne, it's generally the Western numbers are 1 in 3,500 live births. And we are yet to create a huge Indian registry as such, but we have something which we have done for Tamil Nadu. And is there a cure? No. And so, what is MDCRC's commitment? It was more to identify at the grassroots level, establish at the molecular level, and prevent it. When you know there is no cure, there is no point in having more and more kids affected. And so, I have seen mothers with 5 and 6 affected kids. There's no point. There's no education in them, and the public health system has not addressed it. So, we need to first realize it, accept it, and then take action. Then we felt the prevention is very important. Today we have science. 20 years back or 15 years back, it was not there, but today we have it. And I feel our education, if it's to be made more meaningful and to reach the community, the basics has to be done. So we identify at the grassroots level and take action towards prevention, apart from the other services which we offer for the disorder. So Duchenne is not a rare disorder, but a neglected or orphan disorder. And do we know the numbers? No. So we need to plan up. We need to see any action, any policy, we need to know the numbers. And of course, we have done our homework for the state. So identification, which gives you the numbers. And by then you also do the appropriate prevention and care for the children. And so why MDCRC? See the sensitivity in which we started and the way we are working and the community genetics model which we have created. So it's just not a laboratory. You get the sample, you do the testing. That happens all over the world. But we have taken it sort of in depth and we have completely addressed the disorder. And MDCRC's commitment and what we have achieved is like the commitment and its accomplishment is more to redefine Duchenne. We have redefined. Earlier, when a Duchenne child, you can check it up in your country or in your area, wherever you are. Generally, the clinician says, nothing can be done, take the kid away. Don't spend much. No, please. There is so much that is to be done. We need to know the molecular basis. We need to do the DNA diagnostics, which is very important. More towards any therapy today in the thing is based on the molecular thing. What is a mutation? Today, therapies are based, including sort of CRISPR. You need to know what the mutation is. Is the mutation confirmed for us to go ahead? Any gene therapy, anything, any therapeutic strategy which is in the pipeline needs to know what the mutation is. So the molecular level work is very important. Is it only for that? No. You need to work towards prevention. You need to understand the carrier status in the family, the carrier status of the mother, the sisters in the family, and tomorrow to prevent it during conception, to understand whether the fetus is fine or not, you need to know the molecular basis. So we say, please just don't send away the kid saying nothing can. And today with our care, the multidisciplinary clinical care, the children who were sort of succumbing to the disorder by 14 and 15, now our boys are all 36, 37 with good quality of life. So we cannot reverse such disorders. It's very difficult. There is no cure. But you can definitely, as a human, with all the empathy, with all the love, what we can offer is work towards giving them a good quality of life. And this has been achieved with our services and initiatives. So I would again insist on this particular slide, which is very important, like MDCRC's holistic services, which includes genetic diagnosis. So we started with diagnostics, then added on genetic counseling, which is very important. But then we moved over to field and outreach, where it is the reach. So the holistic services include field and outreach, genetic diagnosis, counseling, clinical care, rehabilitation, and more than anything is a family support. It's just not doing the testing, doing the counseling, taking the sample and giving them. No, the family support services becomes the rapport with the family, the touch with them, and being there for them at the time of need, and having annual evenings, bringing them together. So these things really set a huge base for research. And the thing is, they know we are there and we do everything what is possible, what is happening in the is the best. We analyze and then offer it. So I would say this is something possible. Of course, it took time to build it. It would take time to build. It is not easy, but having a holistic sort of setup is very useful for such disorders, which we have sort of proven with our efforts and initiatives. And again, for such things, working with a vision, always for anybody, working with a vision makes a lot of difference. And we worked with a vision 2022, and we said by 2022, Tamil Nadu will be a state where there is no kid with this disorder, no kid with Duchenne muscular disorder who will go unidentified. So if you identify, you can prevent it in the next generation. So that is what we have been doing. And we are continuing the activities for the identified kids with where we are offering our rehabilitation and care services. And for the families, we have been, all the carrier test is done, and the girls who were young and now who are 18, who are going to get married, we are still hand-holding them. And we do the carrier testing. And even if they are positive, we help them through our genetic counseling, which I'm going to elaborate in a few minutes. So ours is a holistic community genetics working model at MBCRC, which we have established. And more the thought process is, we just want to say our genetic services only for the elite? No, it has to reach the rural. If we say, see the city bred ones, yes, they can always go to the clinician, then they can get it tested and they have the economy to manage. But once in the rural, again, the awareness is very less, they need it. And I would say the community genetics model has worked wonderfully at the rural level and is very important. And this all started when we took 5 health unit districts and we did a house to house survey. And it was just with 5 quick questions of, do you have how many children? 3, 2 sons, 1 girl. Okay, do the sons have these quick symptoms like frequent falls, toe walking, waddling gait, calf muscle hypertrophy, and govers? Because Duchenne kids are wonderful. They are born very normal. Till 2.5, 3, they are wonderful. They're healthy, they look healthy, everything is fine. They are mentally very agile. And then the first symptom is a frequent falls. And then it's followed by toe walking or a waddling gait, calf muscle hypertrophy, govers. So these are something which we educated the complete health system. And here we just tick. And there's all these forms. When you, on an average, you could take 3 forms per home, and we close to around 18 lakh houses we screened with these questions. And it was in 5 health unit districts, and we found our numbers were, as compared to 1 in 3,500, ours was 1 in 1,400. So it's around 2.4 times more than the global figures, and there's no cure. So I would say it's so important. It could be more because of our population again, and awareness being close to nil. And so we thought it is very important to cover the entire state, bring in awareness, and then identify, prevent, and offer care for the children already who are affected by it. So this is networking with the districts, training and awareness of the complete health system, the village health workers, training the doctors, roping in college students to screen our forms, because with 18 lakh into 3 per house, it's a huge number of forms which needs to be screened. And again, house to house survey at the rural level, people who cannot reach the camps, then going to the doorstep to do the testing. And then blood draw, bringing back the sample for the genetic analysis, genetic counseling, clinical care. So as I told you, it's a very holistic approach. More generally, it's an inverted pyramid, I would call. And the these patients don't even know that they need to reach the doctor. And through our efforts, MDCRC brought them to the clinician. And it is a typical case of an approach of a holistic model to address such disorders, neglected disorders, mainly a case of Duchenne muscular dystrophy. And so just split it out. As I told you, in outreach, we have training, screening camps, field visit, and awareness campaigns. And then once the sample is bought, we do a complete molecular workup. So you can, during the question answer session, ask me any questions regarding any of it. So for the sake of time, I'm just sort of going through it step by step. If you want any elaborate information about these slides, you can get back on the Q&A session. And then the counseling. See, the genetic counseling becomes very important. You have the molecular data, and now you need to do the counseling. So genetic counseling becomes very, very crucial and important. So how do you start with, see, when you have an index case, you do which is called a proban. You do a pre-test counseling before you collect the samples. And once with the results, you do a post-test counseling. And then you go back with the results, and then you have the family, and you do a pre-test carrier counseling. You take the samples, and with the results, you do a post-test carrier counseling, and then they need the reproductive counseling, prenatal, and of course, for the family and the child who's growing up, who's mentally very agile, who's born very normal, and with all these symptoms, he gets onto the wheelchair by 10 or 12. And you just imagine a 10 or 12-year boy sitting on the wheelchair, unable to play, the mental trauma he will go through. So the psychosocial counseling that is needed, and all this after Corona, we have also sort of developed ourselves in a huge way. Otherwise, we used to have one-to-one. We have us volunteers in all the 28 districts, 45 health unit districts. But now we have also developed in a huge way on the telegenetics platform. So these are these steps, like how do you confirm, you organize the camps, you invite them to the camps. So both for the proband and carrier, we have a systematic process, because process is very important. And then we do in-person counseling, telegenetic, telephonic, and a doorstep. And next comes rehabilitation. See, okay, these are all for the future. Now what happened? My son is with Duchenne. So he needs help. So rehabilitation is very important. Physiotherapy, again, it's not just normal physiotherapy. You need to have a physiatrist again as part of the team. You need to have the physiotherapy assessment, stage the kid, and then you manage through physiotherapy with orthotics, whatever is needed, with all the exercises. So our center has all what is needed for muscular dystrophy. And again, making it more integrated with yoga again. And we have, of course, occupation therapy, hydrotherapy as part of the whole thing. And this is our rehabilitation center. These are our wonderful kids. So making them move free, get strong, and feel better. And these are the modifications, because they are on wheelchair, the basic needs that they would need. So this is just to show how it looks like. And so what does it do? It helps in prolonging ambulation, maintains muscle power, prevents contractures, prevents scoliosis. So it overall sort of improves the quality of life. Okay, so what is the real difference is when you give a child sort of a rehabilitation or physiotherapy, you can see the one sitting on the ball, the same age, the child who has not got a rehab or a physiotherapy or rehabilitation intervention, you see how he is totally bedridden. Same age, same mutation, but when the care is different, you can see how different it becomes. So as humans, I feel wherever possible, we should be able to offer it more for the underprivileged. And then comes the the need for clinical management. That is a part of it. So neurogenetic disorders, then the genetic counseling, a need for clinical care guidelines. And here, just a minute. So we have the multidisciplinary clinical care, all neurological disorders. They need multidisciplinary clinical care, again, more in Duchenne. And here we have pediatrics, neurology, cardiology, pulmonology, gastroenterology. So we So evaluations and consultations are done by all specialties because neurology or neuromuscular need all the clinical specialties for management. And this is a 10-bedded center, I would say one of its kind in the country. And we have national level care related projects. We cover more of rural children from economically weaker section who really need it and would really like to integrate it with the government health system. And the main thing is adapt follow-ups for these children. And all specialties under one roof. You know, all these specialties, if the parent is to take the child who's on a wheelchair, one by one to the pediatrician, neurologist, orthopedician, physiotherapy, pulmonology, cardiology, gastroenterology, you know how much it would cost and what should, and they run from pillar to post because again, most of these clinicians are not very familiar with such disorders which they don't see on a day-to-day basis. So making them and offering them all under one roof makes a lot of difference to the parents and the children. So again, I re-emphasize having a very holistic model makes a lot of difference. And so genetics and public health, a framework of integration of human genetics into public health practice. And it has been a journey from 2005 as such, but as a registered foundation, it's from 2011, and we have crossed around 14 years. So the focus has been identify at the grassroots level, confirm at the molecular level, prevent it through carrier testing and genetic counseling, and care to improve the quality of life of patients and families. And I have some videos, we can play it later. And all this happens because there's been lots of challenges. And when we keep the children, these are our wonderful boys, when we keep the children or the patient as center, then things move much faster and with ease. And I would say it's more voice of a mother because a day when I had a mother with 4 children affected, and it was a day when I had to go to the US, I had the visa interview, but the day I saw she came in for the first kid. She was in rags again, no oil, like no slippers. She came in testing because we do it free for the first kid. But when I saw the second and third one, I felt it. It was 7 years, 5 years, 3 years, and a little baby in the hand. I was shaken. And that is when I decided there is so much of need in this country. And that minute turned my life. See, there's an education. We are educated. And if it doesn't really reach the people for whom it should reach. So that's how my journey started way back in 2005-06. And I never knew it would take me in so much. But it is a very contented as such. And there's a huge need. And if we join hands, so much more can be done. And I would say MDCRC's voice is more a voice for the, and it's a voice of our mothers who really need it. Because generally what happens, if the child is fine, fine. If there's something wrong with the child, always the blame goes on to the mother. And more in a country like India and a few other countries again. So those are, and the mothers are the ones who really need help. And I think with such initiatives, it makes a huge difference. And the sort of more a dream, it is a state-of-art model center where we can handle all muscular dystrophies. Of course, we are doing it now, but there is so much more resources needed to handle all muscular dystrophies, where we can have everything under one roof. The training for the health workers, the camps, the field visit, awareness, diagnostic, counseling, clinical care. And more to say, healthcare is not just for the elite. It is for the rural needy again. It needs to be inclusive. When we talk about sustainable development goals, unless we make it inclusive, then we are really not going to achieve it. And I think one-stop shop of this sort is going to make a lot of difference. And where we integrate the existing work and we diversify to other muscular dystrophy or with other neuromuscular disorders again, and all under one roof. And so the need to set up a state-of-art model center for muscular dystrophy is because there's a huge need, numbers which need to be addressed, and varieties of muscular dystrophies, and lots of other neurological problems. As I told you, you could put in what is necessary there at your place, and it can be worked out. And again, coming to the national policy, every country, and again, India has a national policy for rare disorders 2021. And more to say, a brief comment is, unless you know numbers, you cannot take action, right? See, when you say, go to the government and say, oh, there's an action to be, the immediate question is, what are the numbers? So we have covered the whole of Tamil Nadu, again, for one disorder. but it has taken sort of, it's a very mammoth task, but there is a model which has been established. Now it can be replicated for other disorders and replicated across states, across countries. And I would be very happy to join hands with any one of you to take things forward where you strongly feel, yes, there's a need. Let's work together. We can definitely do it. And policy on any country is to lower the incidence and or prevalence of rare disorders based on the integrated and comprehensive preventive strategies that we, because nowhere in the world there is cure. And working towards prevention and ensuring good quality of life is something which is in the hand. You can do it now, today. I think acting now is very important, and that is what has been achieved through this model. So, genetics and public health, a framework for integration of human genetics into public health practice. It has been a decade of focused, committed work in this area, and it has set a great base for research. See, unless you know the numbers and unless you know all this, how do you do research? Now we are very strong and we are just to take off in research, and it has blossomed beautifully with years. And now the Department of Research is just sort of coming in, and it's a very committed into 14 years of work, and the platform is set beautifully. And so the mission of MDCRC, like the domain in the public health and the community reach being our focus, which is an interdisciplinary approach where we have basic science, scientific methods, and applied science, and the synergy between, bringing in synergy between community researchers, clinicians, academicians, and policymakers. Here it is very, very skinny now. The bridge has to be strong. We have to bring these people together to make something really happen. That synergy has to happen. And we've been in the thing of creating models, working models, addressing clinical needs. And this has happened because of sensitivity. Even today, I have people commenting, why, Lakshmi, you're working on muscular dystrophy? There's no cure. Why so much of effort? Why so much of thing? But the sensitivity towards the whole thing. A young 10-year-old boy unable to stand and run, and having 4 brothers of the same thing. And the mother, just look at the whole thing. So there is science, and we are educated, and there is a possibility to really address it and make the science reach the community. And that is what we have been doing. And I think there is so much more. And I think this need is across the countries, and the globe. The thing is, we getting together and setting our mind, focusing, and then taking things forward. And if it comes at the policy level, and if the resources are provided, it would be much, much more effective, and it would not be too challenging, and it would make more people take in. And this is my wonderful team. Nothing is possible without a great team behind and more work like this. And we are sort of a referral center for the Department of Health and Family Welfare. We have our DSIR, Department of Science and Industrial Research, sort of recognition. We are ICMR Center of Excellence for neuromuscular disorders, and we are the Integrated Rehabilitation Center. We have projects under Ayush, etc. And it has been a great journey. And MDCRC, as I told you, is a not-for-profit foundation. And of course, being a part of India is again re-emphasizing the southern India in Coimbatore. We have worked with the responsibility of a government, updated skill of a corporate, inclusive nature of a university, and relentless striving as a patient advocate. We have brought this all together, more to tell you youngsters that there's a huge possibility. It is possible. And joining hands, it makes it even more possible. And I end it with always saying, Robert Morrison, to do what ought to be done would not have been done unless we did it. We thought it is our duty. So there are not many people who would see there's so much of time. Again, on a Sunday evening, we are talking, and Satpati is trying to bring things together. He was again not well, but the commitment, there is so much more. And so more because we thought it is our duty, and then we need to do it. And I love the Simon Sinek's quote, work around barriers, if not break barriers. When we help ourselves, we find happiness. When we help others, we find a lasting fulfillment. That is something to be experienced. And that I would say in this last 15 years, more than anything, there has been a strong sense of containment and fulfillment of having done something for the community. And always, as you say, if you want to go far, let's all go together. And of course, It was initially a very a lone journey, then people joined, and now we have sort of crossed lots of milestones, and we are where we are. And it has been a great journey again. And always I end saying, together we can make a difference, and we make a difference. And thank you. And I'm Lakshmi, and this is my email. And anything you would want to mail and ask, I'd be very happy to answer. And thank you so much. Thank you. And thank you, Dr. Satpathy.
Okay, thank you. Thank you, Dr. Lakshmi. What a wonderful talk and heart-touching. Participants, this is my second time listening to this presentation with a bit of modification, because first time when I heard this talk, I was mesmerized, and I was convinced that she should be here at the global consortium stage, and therefore I chose that, and I even said, like, we are going to bring you onto our stage, so please do give us time. Okay, so now we'll quickly go into panel discussion, wherein I'll be asking you a lot of questions now, Dr. Lakshmi. Please have a little bit of water, because I know you are not well. So I have lots of questions, and I would request you to please be brief. Why? Because the questions are very complementary in nature. So in case you are unable to answer something, you'll be answering that in the next question. So many questions are very related to each other. So the first question is, how can India accelerate translational research in genetic neurological disorders like muscular dystrophies to bridge the lab to clinic gap?
Very nice question. As such, yes, we are I would say we have been addressing it in pockets here and there. When you say neurological, it's a huge thing to answer as such, because there's so many types. And again, all of it is happening more in the cities where patients have access, things like that. But if we need to see, I would say, when you say translation, bed to lab to bed, which everybody speaks about, I would say the first thing is that there you're talking about a cure. Then you want to take it to the patient. So that is, yes, one thing. But here, most of the neurological disorders, there is no cure. Cure is not there. So it has to be, you have to have multidisciplinary clinical care sort of. So do we have guidelines? So that is the next question. Do we have guidelines for these disorders? Yes, for Duchenne as such, we have international guidelines. And the work which we have done in the past, I would be coming out with the paper where we worked with ICMR very soon, where we are trying to see what is the effect of multidisciplinary clinical care on children with Duchenne. Like, there's no Indian standard. So one thing is we have to set the diagnostics. I would say diagnostics is far sort of set. Okay, when you say neurological disorders, first thing is you have to identify. Before we talk about translation from lab to bed, first thing in the lab, is it all set? I would say we are fairly okay there. Diagnostic is fine. But the reach there, no. There's a huge work to be done on that. It's all reaching the light, and the public health system has to be strengthened. So that is a need over there. Now, the next thing when you have to say is there a cure to take it to the bedside? No. Something is happening in the West. In India, nothing much is happening. But whatever medicine is available, yes, it can reach. So again, there the elites get it. We have to see that public health system offers it to the rural or the underprivileged. That is one. But I would say, to really take off as a country, I would say we have to reach. We have to know our numbers. Then from there, they set a huge platform for research. The need would be there. We can push the government to say, hey, the numbers are this. Come on, you need to fund us. We have to do. And again, such disorders, we can form international collaborations. For Duchenne, we have a cooperative international neuromuscular research group. It's called Synergy, SCINRG, Cooperative International Neuromuscular Research Group. So we can form huge international groups, and then there's a huge possibility. But as of now in India, whatever is there more in the cities or for the elites. Public health system has to be strengthened for it to reach the rural. That is something which needs to happen at least in the next 3 to 5 years. And then you work on the reach, and then, yes, research. Research, I would say, will not happen just like that. If you want a strong research base, we need to work very systematically, and the public health system has to be strengthened in a huge way.
Okay, taking the time limits into consideration, I would request you to be a little bit precise in answering. I know that you have a lot of passion and a lot of wisdom, but whatever you are saying is very relevant, and that is going to be asked in the next question, in fact, So I'm coming there, So what breakthroughs in India's genetic mapping and diagnostic technologies are the most promising for early detection and classification of muscular dystrophies?
Come again, the first two words I couldn't hear properly.
What breakthroughs in India's genetic mapping and diagnostic technologies are the most promising for early detection and classification of muscular dystrophies?
In muscular dystrophies, as such, today with the sort of galloping technologies and companies which are offering diagnostics, earlier it used to be just muscular dystrophy and it was more of invasive procedures, but now we have good genetic protocols which are available. And of course, the challenge always is the variant of unknown significance, no variance. We get, because the diagnostic yield internationally is only around 45 to 50%.
Right.
So that is a challenge, but that needs to be addressed systematically.
Definitely. Okay, the third question to you is, I have lots of questions for you, by the way, so please don't get tired. In what ways can international collaborations be strengthened to foster ethical and inclusive genetics research in the Indian context, especially for the rare neurogenetic diseases?
I would say there are individual patient bodies, or as I told you, groups like Synergy, which focus on it, because we are just not talking about neuromuscular. We are talking about neurological disorders. Yeah, it's so vast, and each of it has huge teams working in the West. And I think groups here, if it can be formed, parent bodies are there, but we don't have research bodies or groups. So I have lots of ideas and plans where we can put them all in a very nice baskets and then put them on network and bridge them beautifully. So there's a huge opportunity there, I would say, and it can be very well planned and done. Possibility is huge,
Sure.
and India can
Yes.
reach that. There's no question about that.
Definitely, and we'll do it together. And the question number 4 is, how do we ensure that caregivers of patients with neuromuscular disorders are adequately supported within our healthcare systems, not just clinically, but emotionally, socially, and financially?
I would say India there's a huge, it's a long way to go. And again, the ecosystem doesn't support it at all. Yeah, the taboo to even bring a child on a wheelchair, I would say even culturally. And again, counseling is so, even genetic counseling, it was so tough. And yes, that was more a technical need. We have addressed it. But when it comes to psychological needs and the backups, I think and caregivers are never given importance. Like, again, it is all mothers. I would say more the women. And as such, we have looked at it very holistically. And I have mothers meeting the psychologist, who's a very, very nice lady. Again, it cannot be a psychology thing. They need to understand the disorder. They need to understand the caregiver burden and be with them. It is not the degree they have, the empathy they have in the heart where they can work with them. So again, this caregiver burden is something, it's a huge need in our country. It needs to be addressed with good planning and good initiatives and capacity building with the trainers who are to be trained, and then you deliver it. I would say it's a long way and we need to do it. It's a huge need.
Definitely, I agree with it. Question number 5 for you. I have 18 questions. I'm just letting you know in advance. What role can multidisciplinary collaboration play in improving the treatment and clinical effectiveness for providing optimal care and services to children and adults growing up with neurodevelopmental disorders, Can you please expand upon this based on your 20 years of experience in this field?
Very true. Sure. Like all these neurological disorders need multidisciplinary clinical care. First thing we should understand, it's just not the pediatric neurologist or an adult neurologist. No. Yes, he is important, but it is multisystemic. See, then you need for pediatric like Duchenne, you need the pediatrician again. Then you need the orthopedician because contractures thing, you need surgery. Then you need rehab specialist. Then cardiac is affected in most of the cases. You have the cardiologist, pulmonology, because these are all muscles, most of it. It gives way. You need the pulmonologist. So I would say the challenge in India is to form the multidisciplinary clinical care team. I know how difficult it was. Like clinicians, even to look at each other's face and work together. I won't say everybody, but the general thing is the culture is not that to getting together. There's no opportunity for the multidisciplinary clinical care team to come together, to work together. That sort of a culture and base is very, very, very less in the country. That needs to be there. And getting to any multidisciplinary care, again, do we have national guidelines? No. It's very skinny again. We need to set our goals to say we need to form national guidelines. So when we have these funding bodies, I would again say it needs to be focused. What do we need? These are the things we need, ABC. We need a national guidelines. And okay, we fund towards the national guidelines to make it happen. So that sort of a thing, if it is planned, this multidisciplinary, which is clinical care, no question, Maheshwar, it is a need. It's a huge need. Does India have it? It could address any other country again? No, we need to put it in place. Okay, how do we put it in place? We need to have resources to put it in place. Every clinician is very, again, in India, the population, not to blame the clinicians, they are very busy. They don't have time. Again, I would say the edge MDCRC has is we are bridging things. Again, the clinicians, none of our clinicians, they are wonderful, but they will never have the time to deal with Duchenne in the way we have dealt. Because we have bridged, because we have made it happen, they still had the heart to come and see the children. Otherwise, it wouldn't happen. So I would say the model created is wonderful. Like it works. We can make it happen. We need scientists to bridge. See, we are neither modern medicine or allopathy or alternate medicine, whatever it might. We are scientists. We can bridge. We understand this, we understand that. And to make all these happen, I think we scientists need to get together, bridge, and make it happen. Otherwise, everybody is busy. That's a fact. But then we need to make it happen.
Very true. The question number 6 to you. Despite the increasing prevalence of muscular dystrophies and other genetic neurological disorders in India, national level clinical guidelines are still lacking. What are the primary systemic and institutional barriers to developing and enforcing such guidelines?
You need a will. You need to be sensitive. You need to understand there's a need. And it's going to serve so many people. Again, the country doesn't appreciate good work. Sad to say. See, these things should be encouraged. Somebody working on it, and you should put a handful of people only for that power. People who see patients from morning 9 to 11, how can they sit and work on this? It never happen. Government needs to put passionate, good, committed, focused people to make it happen. Otherwise, we'll keep talking about next 5 years, 10 years also, we'll be talking about this. Yes, there's a need. Yes, there's a need. I think it should be more a policy decision, and it's a government initiative. It should be from the government in a very strong and authentic way. The barriers are there's no initiative from the government in a strong way.
Yes, I agree. The next question is, with the rising burden of inheritable neurological disorder, what should a culturally sensitive and scalable genetic counseling model look like for India's diverse population? What are the ethical dilemmas you encounter in offering genetic testing and counseling, especially in socio-culturally sensitive contexts like India, and how should national policies address these concerns? I know I'm asking a very complex question.
No, that's okay. See, genetic counseling again as a subject. See, genetics as such in a medical curriculum, it's very skinny in India. Again, since we have started the board of, I'm one of the founders of the Board of Genetic Counseling India. I'm taking this opportunity to tell. The thing is, it has to be, and today was the exam again. Today we just finished 114 people applying for the certification, and today was a level 1 and level 2 genetic counseling exam, which got completed by noon today. So we have created close to 300 plus genetic counselors in the last, this is our 10th year. And we are very sort of, it's not just writing and getting away, it's very meticulous, very stringent, and we want good genetic counselors. And when we say genetic counselors, as you rightly said, the ethical part of it, it's just not the technicality. Oh, it is like autosomal dominant, okay. It has to be very systematic. It has to be very trained. And counseling is a skill. And it has to be empathetic. It has to be non-directive. All of it is there, and it needs to be a course by itself. And again, India at the government level is still sort of struggling to accept it as a good course and thing. And now we have tied up with Skill India. See, these needs have to be understood appropriately at the level where it should be understood, and it should seep through. And these are something every, it's like every 1,000 you say, see, we lack even in terms of number of doctors and things. And counselors is pathetic. And they're not paid well, and you don't have government representation. Good salaries are not given. And so how will a life science student or a genetic student come in and take genetic counseling when the job opportunities? Say opportunity they pay. So because there's sort of a thing between, oh, clinicians can do it all. No, clinicians cannot do everything. We need to understand, like, our hands are full. Certain things we have to sort of delegate and get it done. So that part, and there are lots of dilemmas. See, when you counsel an X-linked recessive, where the mother is a carrier, and you won't believe the whole family comes to sit in for the counseling. You have the mother-in-law, father-in-law. Culturally, it is very different. And appropriately, you need to counsel. So it is something, it's a subject by itself, Satpati. I would love for people who are interested, I would sort of address it separately one day on the ethical dilemmas, cultural sensitivity. It's a huge subject. And again, India culturally, like language-wise, so culturally, again, I would say we need to be more of Asia Pacific culturally, because the way we counsel, rather than to take the Western model for counseling. At least personal questions and things has to be very different. We are very different from the West in terms of socio-cultural thing, which we have to keep in mind and then appropriately counsel. And language is a huge, huge thing in counseling, and you cannot be counseling everybody in English. And you need to know the local language, and which is very important. So you might be a genetic counselor, and if you're Tamil speaking, to go and counsel a Punjabi family is not possible. So you need to have that in mind.
Yes. So the next question to you is, we are halfway through the questions, so I'm going to be very fast now. So the question is, how can India integrate genetic counseling into the primary healthcare systems without deepening existing health inequities or stigma, especially in rural and underserved areas? And how can India scale and decentralize molecular diagnostics and genetic counseling services to reach the underserved and rural population without compromising quality and ethics?
Maheshwar, we have set the model. The model speaks for itself. Like the diagnostic, it can be, each state can just have one. Not more than that. It need not be mushroom. Again, at the government, whatever I have observed is good manpower. It's lacking. What the private corporates can do, the government is unable to do. That's a fact. Not like, at least in molecular diagnostics, where here you can name it, it is all goes to the private. And again, genetic counseling, 14 years, like 2014 we started, we are in the 10th year. Still we are struggling with the government to sort of, we have proven, we have given our time, everything, it's voluntary to establish and have the support from the government, tag from the government. And see, I would say again, it is a will and people to sit together to understand the need at the government level and then to make it happen. I think making it happen is not an issue. Again, even our model, it has worked wonderfully with taking into account all the questions you have answered is answered in the model which I explained. The reach, the diagnostics, the counseling, the clinical care, the caregiver burden, everything has been addressed. See, when a small little NGO like ours is possible to cover, I think the government, with all its strength and thing, should be able to do much more. I think it is just the will, the focus to do. It is
Yes.
possible. There is nothing process or there is no challenge as such. It's
Yes.
all in the mind. We need to make it happen.
I have a separate pair of questions on the investment and policy, but before that, we'll be talking about more on healthcare now. What ethical safeguards are necessary to ensure the informed consent, data privacy, and autonomy in India's rapidly evolving genetic testing ecosystem?
Again, I'm sorry if I'm sounding negative. Uh, it's like in terms of ethics and privacy, of course, we have consents which has been made mandatory, and we from day one have the consent for all the tests that is being taken. We do the pre-test counseling, take informed consent, and then. But still, I would say in terms of there is no HIPAA, nothing is emphasized on the medical records or mainly in genetics as such. The privacy, ensuring privacy, I think there's a long way to go. We are not in par with, because culturally, again, we are very different, and emphasizing these things to make it happen. It started, I wouldn't say is nothing is there. It is something is there, but there's a huge, it's a long road to still go to achieve real thing in terms of privacy, ethics and privacy, mainly in terms of genetic disorders, where it is very important more than any other. A diabetes or thing you can just walk away, but in terms of genetic disorder, when you know a girl in the family has got it, there needs to be lots of privacy in the data that is given. Even today, companies want all the details about the patient, and who does the checking on the privacy which is maintained? Is it maintained? Not, no. The norms are still to be strengthened.
Right. Okay. The next pair of questions are on clinical guidelines and health system. This is regarding what is your recommendation towards development of optimal clinical guidelines development for health services improvement in the neurological and neurodevelopmental disorders in the LMICs in general and in India in particular?
So we need to form good teams, Maheshwar. I would say a national level policy, then state-wise you can form good groups who have already been working, encourage them, then set the system. See, already somebody is working on this for, say, 20 years, 30 years. Their experience is huge. We need to recognize them, appreciate, form it. See, I would say it all starts from the top, like, let's establish the need, give them the time, give them the resources. I would say India doesn't lack in terms of the intelligence or the patient population or anything of that sort. The best of equipment, everything is there, but there's no leadership and there is no focus for this. That has to be there. There needs, yes, you need national guidelines. There should be a leader which is who stands to say, yes, I will get it done. And yes, it's lots of work. So he has to be, he or she has to be backed appropriately in terms of human resources, other resources, has to be backed, and then it is all very doable. It is just that we need to plan and get it done.
Definitely. Okay, that comes with the next question. How can India institutionalize evidence-based clinical protocols for genetic disorders while accounting for resource variability across different states and healthcare tiers?
Again, it all revolves around the same thing, no? Institutions. So when you say medical institutions, you have private, you have government, and you know how government works, how government hospitals are. There, nothing to blame them. The numbers and the population is so huge. You have to have separate teams put in, Maheshwar. Otherwise, it will not work. And you have to have experienced advisors coming, pitching in to regular. And you cannot say you have to work from 9 to 6 and again sit for it. No, you need to. If you go to the US or other countries, it's only in the morning. Hardly they see 5 to 7 patients. Afternoon is given for research. They concentrate, they do it. They are given enough time. They are given here till Saturday evening. Again, Sunday they are sitting and they are still working on it. But then you need to give them the time and space and the resources. I would say if that is given, I think we would do extremely well in all this. We just need to plan and give this appropriately.
Definitely. Should India consider a centralized national registry for neuromuscular genetic disorders? And what might be the policy, privacy, and infrastructural challenge in doing so?
I think ICMR has got an overall genetic disorder registry as such, but I think it needs to be sort of lots more work is there to really make it working as such. And we have we have the Western registry, for example, Treat NMD neuromuscular is a registry in bringing together the US and the Europe together. We have registries, and again there are mandatory items and things like that, and privacy here is very important. I think the torchbearers are something which is lacking in any of these things. You just leave it
Right.
common. Today somebody sits, tomorrow somebody sits. Nobody owns. See, they should. This is my room. I need to keep it clean. This is my organization. See, the ownership is not there. There's no accountability. Ownership and accountability is something. All the questions you have asked, I would say the answer would be sensitivity, ownership, accountability, focus, and leadership. These are something which is really necessary. But we Indians are capable of doing, and I would say lots of more people around the world again who have the intentions, but you have to create the ecosystem to make it happen.
Definitely. Okay, now we'll go to a few questions on investment and policy. What level and type of national health investment is required to scale up the diagnostics, rehabilitation, and research infrastructure for muscular dystrophies in India?
Say the health system needs to understand first the importance of neuromuscular as such. There's a huge burden, and again having more and more, how is it going to work? There is no cure. So what do? You have to increase your diagnostic capability. Again, like as I told you, the rich reach. What happens to the rural, underprivileged? When you say India, it brings in everybody together. So is the public health system addressing it? It can easily address. It has to be focused. Again, the thing on accountability is there. It's not the lack of any technology. It is we have all the technology. Do we have the resources? I would say still yes, we have the resources, but we have to have the mind and put things together. So the policy has to be very directive and focused, accountable, and we need to have sort of evaluation sessions to understand what is happening. It just cannot something happen and you just can't. One little example is when we do muscular dystrophy and when we given for publication, we don't have normal data, normative data. So you understand? So we take some
Yes.
normative data from the West and then compare and give. They say, no, where is the normative data? Do you think creating a normative data is so difficult in India? That small effort cannot be taken. It is not taken till date. You don't have a normative data for any disorder. What is a normative data? Okay, I have muscular dystrophy. It starts at 3 years ago. So I need boys. It is boys. So I need children between the age of 5 and 12 or 18. I need to know how their normal growth is, how the normal walk is, how much time, all the time function test, and all specialities. It's not such a difficult job. Again, I'm saying a small little thing like ours, if we are able to achieve, think at the national levels, how much is possible? It is very possible. But the thing is, we need to first think it is a need and it is possible and we need to plan it out. That's it.
Only when we determine that there is a need and then we come together, I think that's possible. Okay. So the next question is, what role should Ayushman Bharat and state health missions play in covering the long-term care and rehabilitation needs of patients with muscular dystrophies and similar conditions?
Again,
Should play, not what they're playing.
See, I don't want to go to the political thing of it, Ayushman Bharat, the National Health Mission. See, there's lots happening. To say Tamil Nadu is one of the best states in terms of health. There's so much happening. But again, there's so much more that could be done. Capability is there. So much more can be done. And in terms of mainly rehabilitation, capacity building. See, when you say rehabilitation again, when you say neuromuscular, any neuro, see, the mobility is affected, but they need rehabilitation. So, which means person cannot travel 2 hours and go. It has to be in every district. It has to be reachable. And we need to ensure that the transportation happens for them. The reach has to happen, or the person has to visit home and then get it done. I think some, it is happening. I wouldn't say it is not happening, but it can definitely be improved because the numbers are huge and the types of disorders are also many. So I would say district wise planning it well, making it happen is something very important. I would say the basic infrastructure exists, at least in the southern states. I'm not sure of the northern, but then it has to be made rigorous.
Yes. Okay. Given the limited R&D funding, as you were just pointing out, in rare diseases and neurological genetics and LMICs, what models of public, private, or global collaboration would you recommend for sustainable investment and innovation in this sector? And how can India mobilize the public-private partnerships to invest in cutting-edge technologies for neurogenetic disorder management while ensuring accessibility and affordability?
Wonderful question, Satyaki. Because again, government alone to do in terms of resources or thing is difficult. And I would always think there's so many academic institutions. Why doesn't the government choose and say you are responsible for this? We have students, we have the manpower. You wouldn't believe we wouldn't have covered the entire state if not we roped in our college students. You wouldn't believe I just paid 25 paise per hour for those students, but we gave wonderful certificates that they participated in our thing. See, student, and today every other student is with a WhatsApp thing because there's no direction. If you tell them there's a direction, motivate them and inspire them, they will all be there. So I would say again, the other thing is the government always, at least with NGOs, is oh, you're all private, you're all private. It is all government, only we can do. Oh, government cannot do everything. And again, it is not just the capability. There are lots of other things again. Private, the partnerships are very important. And again, two, three things in terms of, I don't know if you've read the book, you should, and I would recommend all the youngsters again. There's a book called Social Value Investing. It is by Dr. E. Mickey and Warren Buffett's grandson, Howard. You should read that book. It's social value investing. So for a social value, the government invests, the public invests, and the private invest in it to make it is for the society. See, end of the day, we all live in a society, and the society has to be healthy, beautiful, wonderful for everybody to be happy, and the investment is done. And that's something which I could vibe with so well. And it is same thing with partnerships. And there should be mutual trust and faith and the delegation of responsibilities. Again, for such things, the government mandate can be you have CSRs, the corporate social responsibility, to make it mandatory and to see the focus and say, okay, this group, there's a huge need over here. And these are the teams which are working. Why don't this corporates pump in or given the money for such things? See, this focus, or I have 100 rupees, how am I, the way we plan, the same thing has to be planned like, okay, these are the needs. I have so much, and these are the things. The partnerships can be made anyway. Focus. We could have a 1 year, 3 year, 5 year plans put in place and see the progress and then take it forward. And it would work wonderfully, Maheshwar, I would say, if we have a plan in place, focus and accountability, it would work wonderfully. And it's a huge need. And there is a need, and then there are corporates, there are things, but we should make it happen.
Definitely. Okay, the last three questions to you. First question. What lessons can India learn from global health systems in integrating neurogenetic care pathways and fostering the community-based support models for rare disease patients?
I would say, see, India again is very different. And I would say for Bangladesh and others where the population is very huge. See, in the West, when you say neurogenetic, and I'm more familiar with muscular dystrophies again, the numbers are very less, handful. And again, our patients used to ask, Madam, let me take my child to the US or UK. Please, we need something good for the child. I would say, whatever is happening there, we are providing it for you. The multidisciplinary clinical care is what I mean. And lots of those things, we have been doing it at our level. There's no hodgepodge just because we are doing free. No, everything is as per international guideline and things are being done. So the possibility is, in terms of capability, there is no doubt. The capability is huge. But the thing is to address the numbers. Our numbers are huge. For that, the system has to be put in place to address both the urban and the rural. That has to be put in place appropriately. And the resources has to be appropriately sort of managed and given to address the needs of this neurogenetic. And again, parent support groups, both in the West and in us. There's lots of collaboration happening, but it can be strengthened. I think forums like yours can again have one of your initiatives is bridging these parent groups from the West and other countries. That will be a wonderful initiative to bring them all together and see all that is needed is there is somebody to hold and bridge and bring things together. If that happens, and it's for some time, 2, 3 years, then it will sort of get together, sustain, and it will grow. But that initial effort has to be taken, and this can bridge. Parent support bodies are strong, and bringing them together will make a lot of difference.
Okay. Okay. How can India's rich tradition in indigenous medicine and community health workers be aligned with the modern genetic research to offer integrative care for neurological conditions? Do you think there is a possibility?
Huge, huge, huge possibility. Example is we did our Ayush project. Excellent results. Again, when you say evidence based, yes, there is evidence, but it's not molecule based. I wouldn't call Ayurveda as alternate medicine. It's a 5,000-year proven good thing. And we could see such great results with Ayurveda for our children. And of course, we are putting together all the results and status. Everything is happening, and we should have our publication very soon. And I would say for such disorders which does not have a cure, what is happening in the West with modern medicine, much more can be done with whatever you call as alternate medicine or something. So when we put through, we said we wanted to see what happens with Duchenne, with Ayurveda, with Homeo, with Unani, and all that. But then it was challenged 3 years, 4 years, we went, nothing happened. But at least we could clinch Ayurveda and we did the project and it has given excellent results. And I would say for neuromuscular, these alternate therapies are going to really, really serve in a big way. And I think investing in that will make a lot of difference. There's a huge need and we can do it.
Okay, the last but not the least, most important question to you. Given the stigma associated with genetic and neurological disorders, how can India craft inclusive narratives through public awareness and media engagement? And what role do you see as a lab scientist and also someone who works at a hospital setting, to play in this regard? What kind of role do you think?
Awareness, as you rightly said, public awareness is something very, very important. And it's just not awareness. Are we backing it up with patient-friendly ecosystem to support them? Is okay, you create the awareness. Okay, they come to you. Where is a system to support? Are we able, are we able to support either the Ayushman Bharat or NHM or in the West, it is all the insurance. So the patient, yes, okay, I understand awareness. Oh, the child has got this. Okay, where do I go? Where is a direction for them? What happens? And is it supported by insurance? I would say partly, yes, in Tamil Nadu we have the CM insurance and that. But again, for genetic disorders, the awareness and things is much, much less. And even you won't believe, on Tuesday I was with the director, MD, NHM, saying, "Sir, we have completed for Duchenne. We need resources for other muscular dystrophy. We have worked with Focus. We have done it. And it is all done and we have completed for one." But again, the priority, and for them, again, people keep changing, the person who sits in the seat keep changing. Again, you have to tell the whole story, and you have to. The thing is, the environment is not that people understand that and take it forward. But yes, there is lots of interest, and then there's a huge possibility that people have started to look at it now. They have started seeing it. They have started to understand it. I think we are not very far away. I think it's going to happen soon, Satpati.
Definitely, definitely. So with this, on a Sunday evening, I took entire Sunday evening of yours. You have been so unwell, and despite that, I hassled you to come on board and spend all this beautiful time with us. Share so much of wisdom, so much of experience that you have gathered over the past 20 years of working in India. And I think this was a wonderful beginning of today's panel discussion. We listened to you, and the praise that you are getting right now is seen, demonstrated in the emojis that our young participants are sending, especially from all over the world right now, in praise of you. And so I'm indebted to you and thankful to you and grateful to you, Dr. Lakshmi. You're my sister and role model. I am very inspired by the work you do, and I look forward to all the opportunities to work with you. The Global Consortium of Global Health places on record the gratitude, and we want to inform you the Global Consortium is organizing this Global Advanced Certification Program in addition to the International Workshop Series. So more than 2,200 participants have registered so far, and they are attending. Some of them are attending live. Some of them are attending live on YouTube also, in addition to the Zoom platform, because we have limitations of seats here. So what is happening is all these participants who become successful in the future, since you have joined today as their course instructor, they will be receiving a certificate with your signature as a sign of tribute to you, as well as an honor for them that yes, they have been taught by you, by an eminent expert like you. So our admin team would be in touch with you regarding the e-signature and also the resource materials which you have used today for educating them. It's been a wonderful experience hosting you, and I look forward to all the future opportunities to engage with you in different ways and different avenues, so that we can do better quality research, not just for Duchenne, but also for other rare genetic disorders, and how to develop better quality guidelines, national guidelines, international guidelines, not just national, because you are such an eminent expert. So why should we restrict it to only Indian case? But we'll definitely start with India. Charity should begin from India, as they say. So it will start from India, but it will definitely go towards the entire world, and that's our goal. And we have many experts who will be sitting with us, who will help us to take the journey forward. And that's all from my side. I'm very emotional at the moment. I'm very happy also that you came despite being so unwell and spent all this time with us, answered so passionately and candidly all my questions. I had like a bullet of questions, 18 questions for you, which is not easy to answer in a span of literally just 36 minutes, 18 questions, 36 minutes, literally 2 minutes each. But you answered them very gracefully, very kindly, and very candidly. And I'm very happy and satisfied with the quality and depth of those answers as well. And our participants must have enjoyed listening to the wisdom that contains in those answers. And I'm sure they'll be responding to you and will be in touch with you. There are many questions for you, actually more than 25 right now. But since we do not have time, and there is a lot of page coming also, so what we'll do, Dr. Lakshmi, is we'll compile all these questions and we'll email it to you.
Yes, you can email it to me and I can respond. Positive.
So yes, so that we'll create a PDF file for that, and we can then share it in our group so that everyone can read it. Everyone will be able to understand what's the response. Okay. So with this, I'm very grateful again, and I'm very thankful again, and I look forward to our future opportunities for our research, which we have been discussing for quite some time. And so the rest dues, please, Faisal, please do the rest of the dues.
Thank you. Thank you. And I wish all the participants the very best. And anytime, anything on this, please feel free. You can get in touch. I'll be very happy to share the experience. I'm wishing you the very best and very doable. And always in education, whatever we are, for whatever we are educated, whichever line we are, if it's going to help humanity. So that's something which the goodness and that experience is something which each one has to experience for that field. And I would say you are in a platform where you're exposed to so much of experience and lots of people wanting to share. And please take down and sync it, and if you have anything you would want to ask, be very open. Don't think, oh, this is a silly question, should I? No, please ask. And you are the future leaders and you'll do wonderful. And lots of good wishes and prayers from my side. And thank you again, Maheshwar and his lovely team. And yes, I'm a bit not well. And as Maheshwar said, no, it's like Indian speakers not sort of. I didn't want to really let him down today, though I just took some medication. And anyway, I'm so happy that I get energy after really being with everybody. Always my team says, ma'am, if you're not well, you come off here, you evening you're all right, because that is the energy I get from work and people. And thank you so much. And lots of love and wishes to everybody. Thank you. Bye.
Faisal?
Thank you, Dr. Lakshmi and Professor Satpathy, for such a comprehensive and thought-provoking discussion on such an important topic like muscular dystrophy and genetic counseling. So that surely have provoked some thoughts in our participants' minds. And we will now take a short 5-minute break before we convene for the second panel discussion with world-renowned Professor Dilip Jeste, a stalwart in the field of mental health and geriatrics. So we'll take just short 5-minute break, and we'll begin just at 7:50 Indian Standard Time.
Yes, exactly. Yes. So thank you, Dr. Lakshmi. I shall message you again once the panel gets over, and please take care of yourself. Yes, you are a big asset to our country.
Sure, sure. Thank you. And I would like to have, because I'm not too sure if I'll be able to sit through Dr. Dilip's thing. And if you can send me the video, I would love to listen to this talk again.
Definitely, definitely. We shall share the link.
Thank you. Thank you.
Sure.
Nice, Dr. Dilip. Thank you. Bye.
Sure. Okay, sir, please have a few minutes wait. We'll just take a very quick break, sir. We'll be back. And in the meantime, please set up the slides and everything. Faisal will be helping you, and we shall start. Thank you. Okay, good evening everyone. Participants, we are on a small break for almost 2 to 3 minutes. Professor Dilip JST is already here with us today, and so please do not go away anywhere. We shall start as soon as we are off the break. Okay, everybody needed a little bit of break after that intense talk that we just had with Dr. B.R. Lakshmi. I think it was wonderful to listen to her, and you have already put a lot of very interesting questions, and please remain patient. Okay, the attendance link will be put by the end of this session, not right now, so please remain very patient. Yes, definitely very remarkable and inspiring. Definitely, Jenna, true. Yes, definitely. Good. We will be connecting with Dr. Lakshmi, okay, and those who are attending the entire session will get the certificate, and you can post it on LinkedIn as well, okay, that will help you with lots of visibility on LinkedIn. Okay. So participants, please put your questions in the question box once the talk starts. Okay, the chat is disabled for the entire time. It will be enabled once the session gets over. Okay, so you can put your feedback in the chat as well, but do not put the questions in the chat. Put it in the Q&A so that we can pick them up at the end and read them, or can compile them and send it to the speakers. Okay. Because many a time during these sessions it's a little difficult to actually, answer everything online. Okay, right. And those group members who are present here, we are going to start just now. Please ask your group members to join as soon as possible, because Professor Justice's session will just start just in a minute's time. We do not have a lot of time. Hazel, are you here? Yes. So, Professor Justice, yes. Thank you, sir. So we are ready now. So we shall start. Okay, Hazel, start.
So, welcome again, everyone, to our second panel discussion of our session 9, organized by the Global Consortium of Global Health Actors, Leaders, and Thinkers, and the Global Health Forum, the Global Brain and Mental Health Forum, and the Bangladesh Institute of Innovative Health Research. So our second panel discussion is about unpacking socio-structural determinants for strengthening global health, mental health, and geriatrics. We are privileged to welcome Professor Dr. Dilip JST, President-elect, World Federation of Psychotherapy, Director, Social Determinants of Health Network, Editor-in-Chief, International Psychogeriatrics Journal. Moderated once again by Professor Maheshwar Satpathy, CEO and founder of Global Alt and Director of COE ECC PHP, India. Professor Satpathy, we welcome you once again to introduce Professor Dr. Dilip JST and take us into the next conversation.
Okay, thank you, Hazel, for the wonderful introduction and welcome of Professor Dilip JST. So this is my utmost honor and privilege, actually, to welcome Professor Dilip JST, MD, Director of Global Research Network on Social Determinants of Mental Health and Exposure Mix, President-elect of World Federation for Psychotherapy, Editor-in-Chief of International Psychogeriatrics Journal, former Senior Associate Dean for Healthy Aging and Senior Care, and Distinguished Professor of Psychiatry and Neurosciences, University of California, San Diego. He is also past President of American Psychiatric Association and American Association of Geriatric Psychiatry. So his CV is vast, and so are his achievements and contribution to the world. So it is my utmost honor to introduce him and welcome him to the stage of Global Consortium of Global Health today. Professor Dilip V. Cheste, MD, is Director of the Global Research Network on Social Determinants of Mental Health and Exposure Mix, President-elect of the World Federation for Psychotherapy and Editor-in-Chief of the International Psychogeriatrics. He is former Senior Associate Dean for Healthy Aging and Senior Care and Distinguished Professor of Psychiatry and Neurosciences at University of California, San Diego. He obtained his medical education in Pune, India, and psychiatry training in Mumbai, India. In the US, he completed psychiatry residency at the Cornell University and neurology residency at George Washington University. He was a research fellow and later chief of the units on movement disorders and dementias at the National Institute of Mental Health (NIMH) before joining UC San Diego, where he worked for 36 years. Dr. Cheste has been principal investigator on a number of research and training grants, mostly from the NIH and VA. His main areas of research include schizophrenia, neuropsychiatric interventions, and healthy aging. He is past president of American Psychiatric Association, American Association of Geriatric Psychiatry, West Coast College of Biological Psychiatry, and founding president of International College of Geriatric Psychoneuropharmacology. Professor Cheste is notably also the past president of American Psychiatric Association, APA. He was the first Asian American to preside over this 175-year-old organization. He was also the first psychiatrist of Indian descent to be elected to the Institute of Medicine (IOM) of the National Academy of Sciences, USA. If we come to the publication metrics, Professor Cheste has published 14 books, including Wiser, Positive Psychiatry, and Successful Cognitive and Emotional Aging. Very famous books, and you can find them all on Amazon and other sources. Over 750 research articles in peer-reviewed journals and 160 plus invited book chapters. He was listed in the Best Doctors in America and in the Institute of Scientific Information list of the world's most cited authors, comprising fewer than 0.5% of all publishing researchers of the previous 2 decades. So Dilip Cheste has a humble H index of 150 and I-10 index of 711 and cumulative citations of almost 90,000. Dr. Cheste is a member of the National Academy of Medicine and was a member of NIMH Advisory Council and NIH Council of Councils. He is past editor-in-chief of the American Journal of Geriatric Psychiatry. Dr. Cheste has received many awards, including NIMH Merit Award, Commendation for Dedicated Service from the Veterans Affairs, and awards from Society of Biological Psychiatry, APA, Institute of Living, American College of International Physicians, National Alliance on Mental Illness, National Alliance for Research in Schizophrenia and Affective Disorders, American College of Psychiatrists, International Psychogeriatric Association, University of Pennsylvania, Pittsburgh, Cincinnati, and Maryland, and Cornell. He has also received honorary fellowship, the highest honor it bestows from UK's Royal College of Psychiatrists, and honorary professorship from Universidad Peruana, Cayetano Heredia, Lima, Peru. He has been a TED speaker. His work has been cited in Time, The Atlantic, The New York Times, Washington Post, Wall Street Journal, The London Times, Public Radio International, NPR, and various other national and international media outlets. His CV is vast. I will fail short of words if I have to actually summarize and describe his work. So with this very short and humble introduction of Professor Dilip P. Cheste, I would request, sir, please illuminate us with your wisdom and all 5 decades of experience in the field. I look forward to listening to you and learn from you. Thank you. The stage is all yours.
Thank you and good evening. And thank you very much, Professor Satpathy, for a kind introduction and for inviting me here. I also want to compliment you on the great work you have done over 20 plus years as a really major researcher of global value, and also for founding this Global Health Forum. It really seems to be doing outstanding work, bringing in scientists and clinicians from various countries and in a really very friendly and useful way. I also want to compliment Dr. Lakshmi for a great talk neuromuscular disorders, especially Duchenne muscular dystrophy. And I really appreciated her focus on basic science research as well as clinical care and the public health. So I'm just again delighted to be here. Thank you all. So let me share screen and see. Can everybody see the slides? Yeah. So, I'm going to talk on healthy aging, wisdom, and positive psychiatry. So this is part of the overall focus on unpacking sociocultural determinants for strengthening global mental health and geriatrics. So I'm going to talk on four different things. The first is healthy aging, next wisdom, thirdly social factors, and last but not least is how can we enhance wisdom and well-being in individuals as well as in the society as a whole. So let me start with healthy aging. What is aging? You know, I'm a geriatric psychiatrist, and when I decided to go into geriatric psychiatry, some of my friends said, "Why are you doing that? It will be so depressing because aging is all gloom and doom. You develop various diseases, disabilities, dementia, depression, and then you die." And I thought that was wrong actually. Growing up in India, um, I continue to be impressed with how older people are respected in India and several other Eastern cultures. Older people are thought to be wise. And this is opposite of what happens in the modern Western world, where there is strong ageism. People think that older people are a burden on the society because they cost so much in terms of the healthcare. And they're wrong. The United Nations actually has declared the current decade, 2021 to 2030, as the decade of healthy aging. And they said that the whole world must focus on the positive side of aging and how we can promote it. So the first thing is that aging does not start at age 65 or 60. That's most of people think that aging, old people means over 60 or 65. That's not the case. Aging begins at conception. We can have the fetus who is 1 month old, who is younger than 2 month old fetus, and so on. So aging begins there and is associated with dynamic balance between growth and development on one side and degeneration on decline on the other side. We think about childhood as a period of growth and development and old age as a period of degeneration. That's not true. Both have both. In childhood, there is not only growth and development, but there is also loss of synapses, for example, during the adolescence years. Similarly, older people, they do have some degeneration, but there is also growth and development. I'll talk about that later in this talk. So when you talk about aging, really there should be two goals we should have. One is adding years to the life. In a sense, we want people to live longer, and that is actually already happening. The number of older people has been increasing remarkably all over the world. But it's not just adding years to the life, it is adding life to those years. In the sense, we want to make sure that those years are meaningful, productive, associated with well-being. So there are two phases of aging. There's a sad phase and there is a happy phase. There's no question about both of these. And some 10 years ago, we did a large study in San Diego. This was a study of 1,500 plus people from age 21 to 100. So the entire adult lifespan. Okay. And so that's what you see at the bottom of this graph, the age years from 20 to 90 plus. And on the vertical axis, we are talking about absence of disability or strong functioning. So higher the score, stronger the functioning. So what we wanted to do was look at physical well-being and mental well-being. And we followed these people longitudinally. So what happens to physical well-being with age? So this is exactly what we expect, right? We know that 20s, 30s, that's a fountain of youth because people are so healthy, right? Physically, as well as mentally and otherwise. So there's no question that this is a period of fountain of youth. But then what happens? Around 40, we start developing some diseases, starting with hypertension, diabetes, later on obesity, cognitive decline, and so on. Sure. So it goes down. So by the time we are 60, the number of illnesses starts to increase. By the time we are in the 90s, most people are disabled in some way. So that is physical. What about mental well-being? And this is what comes as a surprise to most people. The mental well-being goes in the opposite direction. I talked about fountain of youth, 20s and 30s. That is not fountain of mental health. Actually, it is the other side of mental health. This is a period associated with considerable anxiety, depression, stress. Why? Because think about when we were in our 20s and 30s, there are so many decisions we have to make, right? Whether we continue our education, and if so, in what area do we go? Do we take a job? What kind of job? Where do we want to settle? Choosing a life partner. Whom do we choose? How do we work with that person? And there's a lot of peer pressure. And of course, in the last couple of decades, a lot of social media, and the impact is actually negative because you feel that you're not doing as well as your peers and you criticize yourself. So the mental health is really at the bottom in these 20s and 30s. After that, it starts to get better. Not because the stress goes down. The stress never goes down in our life. From birth to death, there is stress of different kind, of course. But what happens as we get older is we know how to face that stress, how to cope up with it, how to overcome it much better than when we are younger. And that is how the mental health improves. So the depression, anxiety, stress, they go down. And even in the 70s and 80s and even 90s, people are happier, although they're physically disabled. So this is something to keep in mind that aging is not all gloom and doom, but there's actually improvement in mental health. And so this was actually our study from San Diego. So are those findings applicable to others? This was a major paper that was published in Journal of Abnormal Psychology. They looked at 600,000 plus people, so more than 500,000 in the US. And they looked at people from the age 18 to 72. And they found that as people got older, the level of psychological distress went down progressively. So this exactly repeats the finding that we had reported, that is, mental health improves with aging. And that led me to believe that there should be something called positive psychiatry. When I was the president of the American Psychiatric Association in 2012-13, my main job was actually to get the DSM-5 published. And as most of you know, DSM is so important, right? It is thought to be a Bible of psychiatry. And I don't think so. I think psychiatry should be much more than mental illnesses. 20% of the people in the world have mental illnesses. Usually, that's the case. 80% people don't have, but 100% of the people have mental health. So why are we focusing only on mental illnesses? Of course, we have to do that as clinicians, and no question. But we also need to think about 100% people with mental health. What can we do to the mental health in general, right? And I found that psychiatry and medicine in general has been paying less attention to health and well-being than they are to diseases. So I made my presidential theme positive psychiatry. Actually, we were the first ones to use the term positive psychiatry in a published article and then publish a book on that. So we defined positive psychiatry as the science and practice of psychiatry that focuses on study and promotion of mental health and well-being through enhancement of positive psychosocial factors like social relationships, wisdom, purpose in life, resilience, and others. And I will talk about them in the rest of my talk. So I mentioned wisdom. And also I was talking about being brought up in India and really emphasizing the fact that older people are to be respected because they are wiser. So as I grew up as a researcher, I began thinking about that. That really, is that true? Can we show empirically that there is such a thing as wisdom? What kind of a thing is it? And one more reason why I was so interested in wisdom was the Bhagavad Gita. Again, growing up in India, Bhagavad Gita is something I knew, read a lot. And the Gita is really a compendium on philosophy of wisdom. It really talks about wisdom in terms of empathy, compassion, emotional regulation, decisiveness, spirituality, right? So the first paper I wrote on wisdom was actually on wisdom in the Bhagavad Gita. I collaborated with my fellow, Ipsit Vaya, who is from Mumbai. His grandfather, Dr. N.S. Vaya, was my mentor, and whose son, Vyang Vaya, is a major psychiatrist in India today. So Ipsit, their son, he's actually at Harvard now and doing a great job. Anyway, so in that paper that we published, we did a quantitative qualitative analysis of components of wisdom as defined in the Gita, and we used some specific online network at that time, talking about 2015, when actually 2008, long before the AI has progressed so much. But even then, we could use this online websites to develop understanding of wisdom. So, and by the way, in other religions also, the wisdom has been described. For example, there are 12 books of wisdom in the Bible. So wisdom has been known since times immemorial, and yet it has not been studied by scientists. Wisdom has not been thought to be a scientific construct until about 1970s, when the first research started in wisdom in the Max Planck Institute in Berlin and University of Southern California. That's when the empirical research started, but it has been growing rapidly. So there have been 2,000 papers on wisdom in the last decade. So people often confuse wisdom with intelligence. So they think somebody is very intelligent, that means he is or she is wise. That's not true. Wisdom and intelligence don't go hand in hand. Some of the most intelligent people with the highest IQ, they are psychopaths. They are mass murderers. They are terrorists. They use their intelligence to hurt the society. So they are intelligent, they are not wise at all, right? So we need to understand clearly the difference between the two. So wisdom, by the way, after we published the paper on wisdom in the Gita, we also looked at wisdom in other facets of literature, but also the empirical studies starting in the 1970s. Based on that, we developed a definition of wisdom that it is a unique personality trait that involves specific components. The most important component is empathy and compassion, understanding other people's emotions and helping them. That's really the single most important component. Emotional regulation, controlling our emotions, not what teenagers do, right? Self-reflection, ability to understand ourselves, our strengths as well as our limitations. Spirituality, which is in a way different from religiosity. You don't have to believe in a specific religion, specific God, but you believe that there is something larger that we can't see, and whatever we call it, spirit, soul, God, doesn't matter, something like that. Diversity of perspectives. We all have different opinions. And in today's world, actually, there's a lot of polarization, right? People think one way or the other way. Nothing wrong with that. People can have different opinions, but that doesn't mean we should be enemies of one another. We can actually be friends with people with whom we disagree. We don't have to agree with them, but we can appreciate their ability to make their own decisions and be friends with them. And of course, decisiveness. I mean, the whole Gita really talks about decisiveness. What Arjuna needed to do was being decisive and make a decision, right? Not being ambivalent. So that is wisdom. And important thing about wisdom, it has a purpose. It enhances a person's well-being and also helps the society's welfare. You know what is the human species called? The human species is called Homo sapiens. What is Homo sapiens? A wise person. So wisdom really is a part of our growth and development as humans. So when we started thinking about wisdom as a scientific area, the first question that comes in, how can we measure it? Well, there are scales to measure different personality traits like resilience, optimism, um, sociability, right? So we developed a scale for measuring wisdom. I worked with a colleague, Michael Thomas, brilliant young psychologist, and we developed a scale called San Diego Wisdom Scale. So as I said, we have 7 components of wisdom. So we had 4 items for each of them. So there's 28 item scale. But of course, that is too long. So we made a shorter version, 7 item, 1 item for each of this component. And you rate each of those items on a 1 to 5 scale. 1 means strongly disagree, 2 means disagree, 3 is neutral, 4 is agree, and 5 strongly agree. And we showed that it has good to excellent psychometric properties, that is reliability, validity. And we have published several papers on it, and it has already been translated into several languages. Like most personality traits, wisdom also has a neurobiological basis. Where in the brain? The brain has, from an evolutionary perspective, 2 parts. The newest part of the brain, which is the prefrontal cortex, and the oldest part of the brain, which is the limbic striatum. What is interesting about neurobiology of wisdom, by the way, this is based on the neurobiological studies published in people who lacked wisdom or who were wise, but they developed a disease or trauma that made them unwise. So we found that the prefrontal cortex was really important, not all of prefrontal cortex, but specific areas, specifically anterior cingulate, ventromedial prefrontal cortex, dorsolateral prefrontal cortex, also insula. And in the limbic striatum, it was ventral striatum and amygdala. So I talked about thinking that older people are wiser. Is that true? There have been a number of studies comparing younger and older people on various neuropsychological components. And we know that younger people are better in several ways, no question about that. They have much faster psychomotor speed, much better memory, short-term memory, long-term memory, physical ability to perform, learn new things. They can learn AI or different languages much faster, right? At the same time, older people are better than younger ones in several areas. By the way, this is based on a number of studies published all over the world that compare younger and older people. Older people are generally better. Again, this doesn't apply to every older person, but majority of the older people tend to have greater emotional regulation. They tend to be more positive. That is, they favor positive emotions and memories. There's more empathy and compassion, more self-reflection. They have more experience going through life, right? That is why they make better decisions because of having more experience, and they're more spiritual. These are all components of wisdom, right? So clearly there's empirical evidence showing that older people tend to be wiser. Once again, one thing I want to mention is that this doesn't apply to every single older person. No, there are some older people who are very unwise. But by and large, aging is associated with increase in wisdom components. Now, how is that possible? How can anything, some kind of, neurocognitive ability improve with aging? When I went to medical school, I was taught that the only thing that happens to brain with aging is that the brain shrinks. That is true, right? The brain atrophies. Gray matter, white matter, there is no question about that. The risk of dementia increases, that's why. But that's only part of the truth. There is also neuroplasticity of aging. Some great work done in the last 25 years shows that the brain continues to grow, but provided you are active. This word active is really important. It applies to people, older people, who are active physically, mentally, cognitively, socially. In those people, numerous studies have shown, by the way, these are studies not only in humans, but also in animals. They show that older humans or animals who are active, there is greater recruitment and more efficient utilization of neuronal network with both the hemispheres working together. When we are younger, the right hemisphere is different from left hemisphere in terms of functioning. As we get older, both hemispheres start working together. So this lateralization goes down with aging. This is even more exciting. There is formation of new synapses, even new neurons, not all over the brain, but specific areas like the dentate gyrus of the hippocampus and periventricular area. If we had said 20 years ago that new neurons can form in older age, people would have said that is heretic. That is impossible. That is not possible. All right. Number of studies have clearly shown that no, new neurons can form in specific areas of the brain, again, in people who are active and so on. And so why are older people positive? Because there is diminished amygdala activation with stressful emotional stimuli. Things that cause increased amygdala activation in younger people, actually they cause less activation in older people. And that's why they tend to be less negative and more positive. Social factors. So one thing I've been interested in for the last several years is what is called social determinants of health. On the medical side, we all strongly believe in the importance of medical factors, right? Those are the things we ask our patient. Do we have history of hypertension, diabetes, smoking, drinking, seizures, etc.? You also ask about if they're physically active. So we think about these physical and medical risk factors as the primary factors. You know what? That is not right. Social factors have greater impact on our health than most medical factors. So what are these social factors? Childhood abuse. And this is especially true for mental illnesses. It's also true for physical illnesses, but especially mental illnesses. For example, childhood abuse increases the risk of schizophrenia threefold. Threefold. There are no genes that come even close to increasing the risk of schizophrenia by more than even 10%. And here we are talking about 3 times higher risk. Social connections are actually the single most important social determinant. Social connections have greater impact on how long we live than any other social or medical factors that we know of. Violence, of course, increases the risk of illnesses like depression, food insecurity, homelessness. So these are individual level factors, but there are also societal level factors like socioeconomic policies. Poverty, for example, clearly would have impact on the mental health care that you receive. Discrimination, and discrimination is of different kinds. There is racism all over the world, right? But there's also discrimination against women, for example, discrimination against LGBTQ people, for example. So there is discrimination which has impact on health. Immigration. Numerous studies have shown that immigrants actually clearly they face a lot of stresses, and so the risk of depression and anxiety and other conditions increases. Incarceration and climate change. So These are important factors that do have impact. And I think it is important that on the medical side, we must realize that they are more important than the medical factor that we study. What about aging-related social determinant? The worst social determinant is ageism. That's what even the United Nations has said, that stereotypes, prejudice, discrimination directed toward people on the basis of their age. Just because you know that somebody is 70 years old, you mean that means that that person must be really starting to get demented with poor physical and mental and cognitive abilities, social abilities than younger person. That's not true. It may be true in some people, but not true in many other people. Poor healthcare access for older people. Social isolation is common, especially because of loss of um, your spouse or family members or friends. And last but not least is a problem in geriatric workforce. We really need to train people in geriatric health. Um, there are more people actually on the pediatric side than on the geriatric side, and that's great. I mean, obviously, we need pediatric healthcare, no question about that. We also need geriatric healthcare. People are getting older all over the world, and the number of people who learn about geriatric health is not growing. So we must really make important focus on that. And one of the big problems that the society is facing in recent years, at this particular century, is loneliness. When we talk about pandemic, we think about COVID, or before that, typhoid, cholera, smallpox. In this century, we are seeing a behavioral pandemic, not caused by any infections, but caused by psychosocial factors. And one of these is clearly loneliness. The World Health Organization reported that loneliness is a global health priority. The studies in the US have shown that 162,000 Americans die every year from loneliness-related conditions. There is more than the number of deaths secondary to lung cancer or stroke. Loneliness increases the risk of number of diseases, including hypertension, diabetes, obesity, heart disease, major depression, suicides, drug abuse, and so on. And by the way, this is based on solid empirical evidence, including longitudinal studies all over the world. No question about this. And in the UK and Japan, there are actually new ministries of loneliness. But it's not merely a health question. It also affects businesses and the government. The good news about this is that there is a vaccine or antidote for loneliness, and that is wisdom, especially the compassion component of wisdom. Why do we say that? We have published 4 large cross-sectional studies, including thousands of people from US, Italy, and other places, that showed strong inverse correlation between loneliness on one side and wisdom and compassion on the other side. You can see this figure on the right-hand side of my figure at the upper level. So you see strong inverse correlation between the two. It ranges from negative 0.51 to negative 0.75. Just imagine how strong they go in opposite direction. And this is not just clinical finding, it's also biological. We have reported that EEG findings are different, and so is gut microbiome. So gut microbiome actually has an important impact on mental health as well as overall health. The more diverse the bacteria, viruses, fungi behind our stomach, the better it is for us. So more diversity of microbiome is associated with better health. So we found that wisdom was associated with greater diversity of microbiome, whereas loneliness was associated with less diversity. And of course, these are cross-sectional studies. We did a longitudinal studies of 1,261 people, and we found that people who had higher scores of wisdom and compassion at baseline, they were much less likely to develop loneliness and much more likely to have better mental well-being 5 to 7 years later. So clearly, wisdom and especially compassion are associated with less loneliness. There are also social factors that are associated with less loneliness. The most important one is, of course, positive social relationships. There's no question about the importance of this factor. Then being married or having a partner, of course, with good relationship is a major determinant of better health. School connectedness for kids. If they like their peers and teachers, that's great. Religiosity and spirituality. Belief in some higher power makes you feel good. And also there are families that are more resilient, communities that are more resilient. So these are all social determinants of positive age, health, including positive aging. So the last part of my talk then, what can we do to enhance wisdom and well-being at individual level, but also at the community level? So are there interventions that improve wisdom and compassion? We did a meta-analysis of randomized controlled trials that sought to enhance a component of wisdom. We found 57 RCTs, mostly behavioral intervention, that sought to increase one of the three components, empathy or compassion, emotional regulation, and spirituality. 47% of those, so nearly half of them, showed significant increase in the level of their specific component of wisdom with moderate to large effect sizes. So there's no question that there are interventions that can improve wisdom, compassion, spirituality, emotional regulation. But what can we do in real life, in daily life? So several things that we can practice ourselves, tell our family, especially the kids, but also the people we work with, including our trainees, for example. So these are common things that everybody should do. One is there's something called three good things. When you go to bed, typically we think about the bad things that happen to us. That's not good. Think about three good things. Good things where we help somebody or somebody else helped us. Volunteering to do help others. Meeting people who are different from us. Self-reflection, understanding ourselves. Self-compassion, being kind to yourself, and mindfulness. Mindfulness and meditation. Numerous studies have shown that they improve health, and not just physical mental health, but also biology. Studies have shown, for example, that they increase the level of pro-inflammatory, they reduce the level of pro-inflammatory genes. Also, they can increase telomerase activity and increase the white matter integrity with meditation. There's a study published from Hong Kong recently in older people. And it's really a very well done study in where the lay therapists were trained to increase wisdom or empathy in their in the people that they talked with. These are people who had loneliness. And this was a telephone-based intervention. They found that telephone-based wisdom enhancement intervention was the most effective. Then came empathy-focused intervention, and finally the control group, which are just a phone communication. So, we all know about AI, and we know that AI is going to capture the whole life, especially health. There's no question about that, right? This may actually be good news, not necessarily bad news. I do believe that these avatars in future can serve as therapists and improve the individual and societal well-being. They can teach empathy and compassion. They can teach emotional regulation. They can teach self-reflection, so we learn from mistakes and autocorrect. They can teach how to accept diversity of perspectives and possibly even spirituality. That's not clear yet, but it can happen. So I really look at the growth of AI, especially in the last 3-4 years with the development of large language models. I think this will have major impact on mental health and psychiatry. So I'm finishing my talk. So what can we do then at the societal level to improve wisdom and well-being? In the last few years, I think most of us will agree, we are living in a stressed out society. Society has become very polarized. There are 2 or 3 force opinion. I mean, this is happening in the US, happening in India, happening in Europe, Australia, everywhere. We have become much more polarized than we used to be. I'm talking about the society. Overstressed, polarized, angry, anxious, depressed. You know, we don't accept the diversity of perspective. We hate people who don't agree with us. And that has led to loneliness. The number of suicides has gone up in many parts of the world, including US and India. Um, and opioid use has increased tremendously, especially in the US. There are 10 times as many deaths from opioid abuse in the US today than there were just 20 years ago. We need to change that at the societal level. So what do we need? We need to promote wisdom and well-being. How can we do that? So we need to assess, teach, and reward soft skills of wisdom. You know, today we only focus on the hard skills. We want to see how the kids in school get the highest scores on math or science or whatever they're studying, right? As physicians, we want to see how they're best in prescribing medications or doing surgery. That's all important. But we also should reward compassion. You know, in sports, for example, the champion is one who defeats everybody else. Should we not also reward sportsmanship? Should we not reward clinicians who are more compassionate, right? Similarly, self-reflection, emotional regulation, acceptance of diverse perspectives, we need to do that as a society at all levels, but especially education and healthcare. We must do that. And that is what will lead to increase in happiness. So this is my last slide. So we can transform today's lonely, distressed, polarized world into a happier, healthier, and wiser society. And so I'm really delighted to be here and working with Global Health Forum. I think these are things that are useful for not just one society or one country, but really all over the world. So again, thank you for giving this opportunity to talk to you.
Thank you. Thank you so much, sir. What a wonderful and insightful talk. So I'll go quickly into our panel discussion now. I hope you're ready. Please have some water because I have a lot of questions for you. You have been here with us for quite some time now, so I understand that you may be tired a bit. So I'll not take much time. I'll start straight away. So, okay. So how do you conceptualize the intersection between the aging, mental health, and social inequality?
I'm sorry, say that again. Intersection between aging and?
So just, this is the document. Yeah, now it is coming up. Actually, I have the questions written up on a sheet and it's just scrolling down and up. Okay, now how do you conceptualize the intersection between aging, mental health, and social inequality, and what structural reforms do we need globally to build resilience in our aging populations?
Sure. So, as I said, aging, what we need to do is look at it in a combined way, that there are downsides to aging, as I said, with physical health declines, risk of dementia increases, but there are also positive side to aging, which we must take into account, which is improvement in certain components, as I said, empathy, compassion, emotional regulation. And we need older people to help younger people. So we need to, society as a whole and healthcare system need to make sure that we take care of older people. Right now, older people don't get good healthcare in most of the world. That needs to change. It's not just physical healthcare, it is also the award or the reward that we give them, the respect that they receive, and the opportunities that older people have for teaching younger ones, working with them. So, as I said, what we need is spreading the concept of wisdom and social connections, especially including older people. So that's actually what we need to do from a structural perspective.
Wonderful. So question number 2, again related to something of that sort, but I'll try to probe further. How do systemic inequalities such as poverty, caste, race, or gender shape the access to mental health care, and how can the health systems be decolonized to provide equitable mental well-being support globally?
That's a great question. And this is a question that applies to the whole world. Question of poverty, for example. And so that is where these social determinants from the public health side are really important, because it is really the government that decides on factors that apply to individuals. So how do you define poverty? That's one thing. Secondly, what do you do to help poor people? Most poor people in the world actually don't have access to healthcare. They don't have access to good food, access to education, transportation. So their health gets worse progressively. So we need to do something about that. There are some good examples of that. Actually, I think the Scandinavian countries do better than most other countries in the world, because there is better healthcare and sort of social connections and so on that they ensure across age groups. So there are not too many people who are ultra rich there, but there are also not too many people who are poor there. And that is what is needed for most societies to do.
Right. Right. Being a student of Professor Michael Mamet from University College London myself, and having studied under him, specializing on social determinants of health, you know, one of the things that actually brings me when I came across your profile, and I've been in touch with you for quite some time now. I was always interested to probe many questions, and I wanted to grab your attention and get an opportunity to ask questions. Today that I have got the opportunity, I'll be asking you a few more questions. So please bear with me. The next question is, what policy mechanisms do you think can address the social determinants like the housing, employment, and education that often precede and perpetuate mental health issues across life stages, as you just mentioned?
And again, that's a great question. And that's an important question. We really, and that's what the World Health Organization is also talking about, that we need to take a look at these social policy issues that are determined by the governments in different places about housing, food, income-related access to resources. You really need to make sure that they're available for every single person, especially poor people, minoritized people, people who are immigrants, people who belong to discriminated communities, as I said, like racism, for example, women, LGBTQ, so on and so forth. So what needs to happen is that the society becomes more truly democratic. In the sense, I'm not talking about democratic as a party or something, but where you agree with the fact that every human being deserves good care. That's our responsibility as human beings. How can we not do that? And this is something that needs to happen at the global level, at the societal level. And this is like the question that people asked Dr. Lakshmi, and she responded also. This is that we need to try to bring people together. And again, that's why actually I compliment the Global Health Forum, that we need to discuss these questions in an international way. How can let us take examples of good places that do that, also bad places that are at the other end. And these things change over time. But it's really important that we focus on ensuring that every person is well taken care of. So that's really the societal wisdom I would ensure.
Definitely. Okay. What a brilliant and candid way to respond to that. In fact, we need to come together to respond to such challenges collectively, and that's definitely the way forward. Question number 4 to you, sir. How can we shift the research and clinical paradigm from a disease-focused model of geriatrics to a strengths-based, dignity-centered approach to aging and cognitive health? And in what ways can the Global Mental Health Initiative be reframed to move beyond biomedical models and prioritize the trauma-informed, community-rooted, and culturally resilient care?
Again, great question. And this is something really important. I think and especially in psychiatry, we need to do that. I find that oncology and cardiology do more of that than psychiatry does. So coming back, we really need to focus on health and not just illnesses. But this also applies to people with illnesses. So, but everybody, so what we need to do, our assessments need to improve. Right now, what do we do in assessments? The only assessments we do are for illnesses, symptoms, risk factors, and mostly medical. We don't ask about protective factors. So I talked about positive social determinants, right? Social connections, religiosity, school connectedness, and so on. Similarly, on the psychological side, wisdom, compassion, empathy, etc. So what we need to do is the assessments that a medical student or a resident or a fellow or a psychiatrist does must include scales for resilience, optimism, wisdom, and not just for psychosis, depression, stress, anxiety. I think we focus too much on symptoms. That doesn't mean we should stop assessing. No, we must, but we should equally importantly assess these positive psychosocial factors, which are helpful in understanding. And actually, we can help patients a lot by that. If we find that somebody, for example, lacks social connections, and we can then try to find out ways in which we can improve social connections, that person's health will improve. It will not improve by giving some other medication. It will improve because the social connections have increased. And that is something we can't do on ourselves as psychiatrists. We need to work with social workers, nurses, other people, the families. Again, so it's really, it is a global healthcare system. So that's important. That will make it possible.
Definitely, sir. Okay, I have 18 questions for you. We have just been over with 4. So I'll be very quick, and I will request you to take all your time, because our participants are truly enjoying. They are sending a lot of emojis right now. So question number 5. What are the emerging socio-structural vulnerabilities for the elderly in both global north as well as global south? And how can we reimagine aging with dignity in policy and practice?
I'm sorry, can you repeat the question? Sorry.
Yes, sure. What are the emerging socio-structural vulnerabilities for the elderly in both global north and global south in today's climate, because so many changes, dynamics are happening? And how can we reimagine the aging with dignity in both policy and practice? Because many times, many things are just imagined and kept at the paper level, at policy level, but never translated into practice, never reintegrated into practice. So what would be your view?
Again, great point, great question. But this is really what needs to happen. That I think this whole society needs to understand the importance of aging, especially healthy aging. And healthy aging, actually, if we promote it, that's good for younger generations. So sometimes people think that if we spend money on older people's care, then we are taking money away from child.
Yes.
That's not true at all. You know, number of studies have shown that the best intervention for improving social connections are intergenerational activities.
Yes.
So there have been studies that have shown that when older people, say, worked, those who are retired, work in elementary schools and help the kids there. And so there's a large study called Experience Score. You can actually Google and find that there. That showed that when older people worked with younger ones, both of them, they improved markedly. It was a randomized control trial, including a few thousand people, that both younger and older people, so their well-being improved, their biology improved in terms of the biomarkers of aging, biomarkers of stress, and even the brain structure, including the prefrontal cortex. So that is what needs to happen, is changing our attitude toward aging as something that is bad, etc. But really thinking about that as something across the lifespan, something that is useful for younger generations. And again, all of us, are going to be older. So it is good for us, right?
Yes.
For every single person to think about what society will do as we get older and not just discard us, right? So I really think that what is needed is this kind of change in our thinking, feeling. And so that needs to happen through social media, general media, and we need to spread this message. And we need to start at the kindergarten level and the school, colleges, medical schools and so on, I think they're only things are going to get better, but I really think they will.
The next question is in fact going to give you a little bit more time to expand on that point. How can the intergenerational solidarity and caregiving infrastructures be strengthened in rapidly urbanizing and economically strained societies?
No, that's again so true that is some societies, and again, this is more common in the modern Western societies. There's a generational gap, and people are paying more attention to younger people, and actually, the younger people's health is going down. So compared to 30 years ago, today younger people are more likely to commit suicide, more likely to have stress, depression, and so on. And older people are doing better because the society is improving to some extent. But I think what we need to do is see how we can improve that kind of behavior and help both the younger and older generations. So it is not one versus another. We must always think about and not or. Because we are all, everybody is going to get older. And so from that perspective, what can we do to help ourselves and help others?
Yes, definitely. And a true and authentic appreciation of growing older gracefully is something what we need as a society, global society. Okay, the next question. In light of the rising global mental health burdens, how can the geriatrics and psychogeriatrics be better integrated into universal health coverage frameworks and social protection policies? What role can social protection schemes such as pensions, long-term care insurance, etc., play in globally?
Again, really important question and very well made point. Clearly, the social connections need to improve. You know what? Actually, what is needed? We need some studies looking at the cost of healthcare. When we are improving social connections, we are improving access of older people to healthcare. When that happens, we prevent illnesses. And so the risk of heart disease and stroke may go down, not may, will go down if we provide care to older people who are not receiving that right now. So if we improve older people's social connections, what will happen? Their health will improve. And when the health improves, that will mean reduce risk of heart disease, etc. So the cost of healthcare will go down. And so one of the important points about positive psychiatry that I talk about, why we should focus on positive things like social connections, empathy, compassion, they prevent illnesses. There is primary prevention, secondary prevention, tertiary prevention. That's much more likely to happen with these positive social factors than just by looking at the risk factors. And that is what is happening in the healthcare system. So what is needed is actually we need to work together with economists, healthcare economists, and get data, economic data on the cost of healthcare when we provide these kinds of social resources. And we can also look at how much it costs. I promise you that the cost of providing the social connection would be far smaller than the cost that we save by reducing the number of illnesses. So that is what is needed, because that is what will change the policy. When they say, so we are not doing this for older people because of morality or spirituality, that is moral obligation. No, actually it is smart from the financial perspective. That if we focus on healthy aging, that will reduce the cost of healthcare. So I think that is something that needs to be stressed, because then only the politicians and governments will start paying attention to it.
Sure, definitely. So my next pair of questions will come from the theme global health systems and social justice. So we'll probe them further. How can we redefine strengthening health systems to prioritize social justice, power redistribution, and community agency, especially in post-colonial and marginalized geographies?
True, again, these are all really important questions. So actually, I want to compliment you all for asking this. I mean, because these are the thoughts that we need to have, even just thinking about them. And this is something that we should be discussed in any kind of health meeting. These kinds of issues. So, as I said, it really relates to education and healthcare. We need to keep this in mind in educational system, starting at kindergarten and going through college, medical college, and so on. And likewise, of course, in the healthcare system, including healthcare economics, as I mentioned. But I think the more we look at the positive side and looking at from the point of prevention, I think it will have greater impact. So one thing also I want to bring up again is AI. I mean, I think people don't talk, especially on this mental health side, people don't talk much about AI because they say, oh, AI is bad, AI can't do anything. How can AI teach anybody to do anything right thing? That's actually not true. Again, what is happening to the AI in the last 3 years? These large language models, it has dramatically changed things. And I will tell you, it will change the things in the next 10 years far more than we ever imagined, truly. So right now we think that, oh, the computers, the robots can't do this and that. That's not true. Increasingly, the future AI, future robots could be very effective therapists, including psychotherapists. Of course, we need to be careful that because AIs can be misused and they can be used by terrorists and mass murderers, etc. Sure, there is that risk. But there is also positive something that we can do. And I really think from psychiatry side, we got to do that because that is something that will reduce the cost of care. And whether we like it or not, people are going to focus on AI, everybody.
Yes.
And we as psychiatry people, we got to get into that and not say, oh, that AI has nothing to do with mind and brain. Not true.
True, very true. I think we need to respond to the change, and change is the only constant in nature. And those who respond to it successfully and effectively remain the survivors. So in a way, Darwinian law is a little bit applicable, even if people are critics. So the next question is, what structural shifts are necessary to center lived experiences, social accountability, and community ownership in global health research, funding, and implementation?
True. Again, great point. And, talking about Darwinian perspective, Darwin was wrong actually, in one way, in the sense, this idea that, so the Darwin's hypothesis is that most of the older animals die. So animals die and humans should die when we stop reproducing. Because our species survives because we reproduce. We have babies that replace the people who are dead, right? So when do we, as humans, have stopped reproducing? Around the age of 45, 50. That's the age of menopause in women and andropause in men. So according to Darwin's hypothesis, we should not pay any attention to people over 45, 50 because they're really not useful for the society, right? He's totally wrong because there is something called grandmother hypothesis of wisdom. So there are actually major data which have been published in the highest journals in science like Science and Nature, etc., that show that if there is grandmother helps her adult daughter raise children, then the adult daughter lives longer, she is happier, and she produces more children. This is the grandmother hypothesis of wisdom. And this has been shown in humans, of course, but also in dolphins and whales, the two other species in which it is seen. And so this idea that people bring up that why are we wasting money on older people's healthcare? What are they going to do? They're absolutely wrong. Because again, and by the way, these are biological data, evolutionary data that involve thousands of people all over the world, numerous animals, and as I said, they published in the highest journal we could think about, like Science and Nature. So this is real science. It is not just somebody's concept. And so we have to accept the fact that Darwin was wrong, and that we need to change our thinking along that line, because it is in our interest. It is in interest of the species. So we are not doing it because older people should be cared for and we care. No, it is because it is good for younger people. It's good for the species.
So one thing which can be an antithesis to that is, we approach it from the perspective that the one who actually is active enough and is contributing is not necessarily only the young. It can be also old and people across all their lifespan. So therefore, what needs to be adopted in 21st century is a more holistic or eclectic way of looking at the life course development, human development, and as we grow older and how we contribute and engage with the society. One of my long-lasting areas of interest is how we engage with each other as humans, and also what sort of engagements keep us engaged with the universe, with the society, with everything that we do, literally. For example, why are we organizing these workshops, for example? Many people have asked us in the past 10 weeks. Today we are completing the 9th series, and it has taken quite a lot of pain to organize this series, and completely altruistically, without any motive, literally no funding, no support, nothing. Why are we doing it? So it's not because we are going to become famous, world famous or anything, nothing like that. We are doing it because we want to do it. We want to support our younger researchers, so help them and mentor them so that they emerge as the future generation leaders, and that's why we're doing it. So one of the things that I was associated with Professor Wang from Canada, I'm associated with the International Network for Personal Meaning, IPNM, and it's a very brilliant network, where we explore that your individualized meaning, you as an individual, what meanings do you derive out of your engagements with the society, with anything that you pursue, and what it brings to your life as well as to the society that contributes to your overall value and your productivity, your life satisfaction, well-being, and many other variables, obviously. And that's something which I completely agree with, and I have been associated with their network for 10 years now. I'm a life member of that. I think that is something which has a lot of contribution to do, especially to human development perspectives, to understanding it better and making it better maybe, and especially to the gerontology and geriatrics as a field. So I'll go quickly to the next question. We are getting serious about a few more questions about global health, because this is hosted by Global Health Forum, so I'll be asking you lots of critical questions related to global health. In what ways can international donor and health aid systems perpetuate the structural inequities, and how they might be redesigned to build resilient, equitable, and self-determined health ecosystems?
I'm sorry, I could hear the last part.
Sorry. In what ways can the international donor and health aid systems perpetuate the structural inequities, and how they might be redesigned to build a resilient, equitable, and self-determined health ecosystems?
Yeah, great point. I think we really need to bring together is healthcare, finances, and various other societal entities to think about life as a whole and individuals and each type of individual. Think about that. As I mentioned earlier, that the Homo sapiens, the word means actually wise person. And what is a wise person? Wise person means somebody who has empathy, compassion, emotional regulation, self-reflection, etc. But also, again, from an evolutionary science perspective, we are a social species. And that's not true for many other species. There are a few other species that are social, but not humans are essential. Because think about this, when a child is born, and until the child is about 5 years old, the child cannot survive on its own. The child will die. 2-year-old, for example, left to. That doesn't happen to most animals. 1-month-old dog can survive. It doesn't need that. Similarly, humans are really unique in the sense we have this early life period in which you are very dependent on others, especially the parents or other parent substitute, right? If a baby doesn't have parents or parent substitute, the baby will die. There's no question. And that lasts until about 5 years. So this is really unusual because that means that when we are born, we are not there for survival at that time. So we need others to help us survive. So we have to keep that in mind. Why we need socialization, not out of spirituality or not out of helping others or morality. No, it is because evolutionarily we need other people to help. Now, that doesn't mean that we have to be friendly with everybody. No, we can have enemies. There's nothing wrong with having, because we can have differences of opinions. That's fine. But we must have some social connections that are strong and positive. No baby will survive if the baby didn't have strong, positive social connections, right? But that is not true only about baby. As we grow older, that still is true. Definitely, that's true for very old people who have disability. They're like a 2-year-old baby. They have to have others. So it is really important that. So the points I'm making is something to keep in mind. This is not for again the purposes of morality or this is good or ethics. No, the biology and evolutionary data show that we need this. So we are not doing anybody a favor. We need this for ourselves. And so, for example, so helping poor people or marginalized people is not just to help them, it is help us. Because that is how tomorrow if there is nuclear bombs and we destroy the whole world with nuclear bomb, what will happen? There will be no human left, right? If you don't want that to happen, how will that be? We need to have social connection. Only those will prevent that kind of thing. Because we say, no, we don't want nuclear bomb because we really love those people there. So that is something and that goes beyond health system, education system. And that is why geriatrics becomes important because geriatrics is the area that is most neglected and discriminated by the healthcare system overall. Because again, older people, that's the thinking, right? But they're wrong. And they're wrong, again, because the data show that they're wrong.
Right. Wonderful. So I have 6 more questions. Not 6, actually 8. I just noticed. Okay. How can the urban design, environmental policy, and social housing be leveraged as public health interventions, especially for mental health and geriatric populations? Because you just touched upon a little bit, but I would like you to expand on that.
I'm sorry. You can hold this
Urban
closer to
design.
your. No.
Yeah, how can the urban design, environmental policy, and social housing be leveraged as public health interventions, especially for mental health and geriatric populations?
Again, good question. I mean, this is something I think that one needs to focus on, and especially I think what happened, both geriatrics and mental health are paid much less attention, have been paid much less attention over centuries. And even the modern medicine doesn't do much to them. Again, because of this thinking. So mental illnesses, for example, there is so much stigma against mental illness. Why? Because we don't understand, most people don't understand them. How can somebody have, delusions? I mean, that's a bad person, something like that. Well, no, I mean, that just like having a stroke, it is like having a delusion. So similar types. And so what is needed is actually reducing the mental health stigma as well as aging stigma, ageism. That is something that needs to start from the beginning, from our education. And I think as psychiatrists or as geriatricians, that's something we need to keep in mind that our core is not only to treat our patient, that's important, but spread the word. And again, spread the word about the importance of that for the other generation, younger generation, for the society as a whole. I think people, when they see the data, I think they will change their mind.
Definitely, I agree with that. I think data is one that missing link, which has made it very difficult.
Right.
And
Exactly right. Exactly right. Yeah.
One of the reasons why we have so much stigma is because regarding many things, not just mental health, but even LGBTQI community, many other things, very sensitive topics. It's purely because people don't understand it enough. Society hasn't put in or hasn't invested as much as it should have, ethically speaking. Okay, I go to the next question quickly. What are the most effective intersectoral collaborations, for example, health plus education plus social welfare and legal systems, that have tangibly improved health outcomes by addressing structural barriers in your experience?
Yeah, again, I think it again depends on the individuals involved and the system involved. And that changes by culture, that changes by countries, so different places have different outcomes. I think if we though sort of focus on sort of good models to employ, and that's why I was talking about these Scandinavian countries, where they keep the data, by the way, on everybody from birth to death. And so you can go to the Scandinavian record and you can find data on every single thing from very thousands of people over a number of years. And that is something that needs to happen, that we pay attention and assess people on both negative sort of risk factors, but also on the positive protective factors, preventive factors. And if we do that for a period of time and publish those or talk about those, people will see that their previous beliefs were not right. To give one example around that, uh, something positive is sexism. I mean, if you look at the human history for centuries, women always were thought to have a different role, and that women were not capable of working outside. So it's like when the humans are the hunter gatherers and then the hunters and gatherers, right? The men went out and they did the work and they killed and so on. And the women were at home and they just took care of the baby, they cooked. And that actually continued until recently. Now it is changing. People are finding that women can do so many things as well and often better than men do. That's so terrific. How did we miss that? How did the society miss that for centuries? What do we do? Let us start someplace. And again, I want to use that as an example because that is something that is happening. Again, it has not happened totally. Still, there is sexism. But clearly, women are having much more important roles and they're showing that they deserve. And they deserve even more than what they get. So that kind of a thing we can then apply to old age discrimination or discrimination because of mental illness or something else. So let us take a look at those positive examples.
Right. Okay. Sir, I'll be very quick because you have been here for quite some time. I know that you may be tired. And so how can global public health curricula and training be transformed to integrate the structural competency, anti-operation frameworks, and the critical global health theory?
I think clearly our education needs to include these things. Our clinical care needs to include those things. And the system that compensates for the healthcare needs to include that. And so it really is related to education, healthcare, and provision of services. So one thing to keep in mind is not only psychiatry, we must include, as I said, psychologists, nurses, social workers. It's critical to have that. So it becomes a multidisciplinary team. And I take a look at psychiatrists as a leader of a team rather than strictly a care provider to the person with mental illness. It is much broader. And so our responsibility is not only to our patient, I mean, obviously we are responsible, but also to the society as a whole. And again, using positive example, showing how it works. And I think we should become role models. So what I would suggest is there are role models, and I'm sure in the Global Health Forum, you'll find in different countries, different culture. Talk about those, use them to sort of think about, not only for others to think about them, but also see how that was practical. How could they do that? And then that helps us learn how we can do that. So again, really, Global Health Forum can do something that most other organizations cannot. So you have this opportunity to do something really unique.
I hope so, and I pray so, sir. Together we can do it. Question number 14 to you. What role can Global South-led research initiatives play in redefining the successful aging beyond biomedical models, especially within the collectivist and resource-constrained societies, for example, India?
I'm sorry, I didn't hear the first part. What role, who would play, you said?
Yes. What role can the Global South-led research initiatives play in redefining the successful aging beyond biomedical models, especially within collectivist and resource-constrained societies?
Again, great point. Yeah, this goes beyond healthcare system. I think so there is something called age-friendly community. the World Health Organization started this about 20 years ago. And what it is these are communities, sometimes cities, that have that follow the age-friendly focus. What is age-friendly focus? It is not just healthcare. That's my point. So here, older people can learn more. So there are educational opportunities for older people. Older people have more job opportunity. They can teach others. So not only learn something, but also teach others. There are jobs that are open to them. There is much less discrimination. The transportation is friendly for older people. Typically when there is a red light, the red light stays red for 5 seconds. You can't really go in 5 seconds. So really for older person, it should be 20 seconds. So something like that should happen. In the sense, don't think about only the healthy younger people when we define our rules for various things. So in these age-friendly communities, you think about older people as the individuals to whom whose needs we need to meet in every which way. So they're not discriminated against. They can be leaders. Often people think, oh, somebody is
Yes.
80 years old. How can he or she take a leadership role? No, they can. Actually, they have so much more experience. They can do a better job than somebody younger. So I think it is really the whole society's thinking that needs to change. So this age-friendly community, I will strongly advise people to just read about that and see if we can develop it in your own community.
Definitely. So now we'll move to something more serious like ethics, voice, and participation. So the first question in this series is whose knowledge counts? How can health policy making platforms genuinely center the voices of elders, persons with lived experience of mental illnesses, and marginalized communities?
Again, very, very good question. I mean, this is whose voice counts. I mean, obviously, everybody's voice counts. There's no question about that. But typically, we don't hear the voices of people who are suffering. We don't hear the voices of people with mental illnesses because we say, oh, somebody has schizophrenia or bipolar, etc. How can we really count on their opinion? Not true at all. That's wrong, actually. So similar things about children or older people and so on. So everybody's voice counts to different degree, though. In a sense, I think we have to realize that, for example, a person with schizophrenia says, I don't want to take medication because I don't have delusions. That's not good for that person because the person has delusions and needs medication. So sometimes we will have to overcome the person's belief by what is good for the person, decided by the therapist, right? So my point here is that we should take everybody's opinion into account, but sometimes you may have to disregard some opinions because they're not useful at that level. So again, I think that in the US, sometimes it is a problem where there are some strong mental illness advocates who say that you cannot force a person with schizophrenia to take medication if the person doesn't want. That is wrong, actually. The person has serious sickness, is delusional, hallucinating, the life is suffering. So there we need to overcome and their beliefs are not coming because they truly believe. That's a part of their illness. So that's something worth remembering, that we must respect mentally ill persons' beliefs, but not when they're sick.
But I think as a collectivistic societies like India, I think we do a little better in that regard because we take it as our responsibility to show sort of responsibility towards people suffering from especially severe mental illnesses, and we try to reach out whenever necessary or possible. But in Western countries, the rules and regulations, the laws are framed in very different ways. I think that is a limitation in some ways.
I'm glad you mentioned that because it's something I want to mention. That so often on the Western side, the belief is that what the West does is the right thing, and the other lower middle income countries don't. That's actually wrong when it comes to mental health. Mental health, the prognosis of mental illnesses is better in Asian and some other countries than it is in the West. There's no question about that. There's a large study of pilot study of schizophrenia in the 1970s that showed that people with schizophrenia were more likely to recover in India and in other sort of similar countries than it was in US and Europe. And that is because, I think, because of our larger families, the social connections are better. And we believe in interdependence, whereas the West depends totally on independence. Everybody's independent. Well, it cannot be. You have to have interdependent. So your point is again very well taken, and that's something also I want to stress in Global Health Forum. Talk about the positive side of low and middle income countries that teaches something to these high income Western countries.
Yes, sir. That is in fact one of our biggest taglines, that we are the global alternative. You know, so breaking all the narratives and rhetoric that persists for centuries. We are trying to break that, and we do not necessarily think like whatever happens in the West is the very best, and we are trying to break that narrative systematically again. So, what ethical frameworks are needed to guide the structural health interventions that may disrupt the long-standing socio-cultural norms or political power dynamics?
I'm sorry, I'm having some problem hearing sometimes.
Okay.
So my
Yeah.
problem.
Sorry. What ethical frameworks do you think are needed to guide the structural health interventions? Because we have been talking about structural health changes and interventions that may disrupt the long-standing socio-cultural norms or political power dynamics.
Again, very good
Because
question. I mean,
it's not going to happen just by cosmetic changes.
Right. No, I think we need to take into account all of these ethical concerns for the patient care. There's no question about that. It is so critical. I mean, how can we not take into account? And by ethical, I don't mean just the patient, it's also the family. The family has to be included in most cases. Occasionally, the family may not be protective and so on, but most families are protective. And actually, along that line, I should mention something. The US, the National Academies of Sciences, Engineering, and Medicine, that's supposed to be the highest body of science in terms of medicine and, of course, engineering, etc. But they published a report called Whole Health. Okay. And they said whole health, because what is health? Typically, we think about physical health or physical mental health. Whole health is physical, behavioral, spiritual, and socioeconomic well-being as judged by people themselves and their families. This is really important. By the way, this is really a very major organization, and this is something that will impact health over a period of globally, but at least in the beginning, US. What they are saying is it is not just the physician who diagnoses and say this is what we need to do. No, the patient and the family also have a right deciding what they want, what they need. And the system must take that into account also. And that is where the social determinants come into play. For example, if the patient doesn't have transportation to go to the clinic, the patient will not go to the clinic and will have a higher risk of relapse. Should we not find transportation to the patient? We must, right? But that is not part of something that that's not included in the medical assessment.
Yes.
So coming back, I think where the things are going to change, they must change. That physician-made diagnosis is not the health. That it is actually the patient and the family best suggestions for what they have, what they should do. And again, they don't determine everything, but a comprehensive perspective that takes that into account is critical. And it is not only critical for the patient's health, critical for the whole society. Because if you do properly, the patients are less likely to develop other illnesses, so the cost of healthcare will go down.
True. Okay, I have the last two questions for you, sir. How do we ensure that innovations in digital and AI-based health solutions do not reproduce or exacerbate the structural exclusions, especially for older adults and mentally vulnerable populations?
Sorry, just repeat the question, please.
Yes, it's a little, because you placed AI.
No, actually,
which is,
I use hearing aids. No, I use hearing aids. So it's my
okay.
problem. It's
Okay,
not
sorry.
your
problem.
Yeah.
Okay. How do we ensure that innovations in digital and AI-based health solutions do not reproduce or exacerbate the structural exclusions, especially for the older adults and mentally vulnerable populations?
Again, great point. That's something we got to think about, that with this development of AI and things that are going to change. People are worried about what happens to, especially mental health, and what happens to older people, because the older people have cognitive impairment, so they won't learn the AI quickly. And then the mental illness, of course, how can the AI understand the mind and the brain? It can't, and so on. So that's the thinking. And we must keep that in mind. So there is no question that we have to take into account that there is a risk of something going wrong for people with mental illnesses and for older people. Nonetheless, that doesn't mean that AI will not have a role. I really think increasingly, and actually I'm not a technology expert, so it is not coming from, but honestly, I think that the AI of the future is going to have major impact, positive impact on mental health as well as health of older people. Let me just give you one example. The number of older people in the world is increasing, right? There are 8 billion total people, and the proportion of people who are over 60, 65 is growing rapidly.
Yep.
Do we have enough therapists or clinicians to take care of them? Not remotely, right?
True.
Even in a
True.
country like US, there are places where there are so few uh, physicians, for example, another clinician. So the current system, which counts on these physicians as psychiatrists offering psychotherapy, is totally wrong, because it hurts the whole healthcare system and the economy. What the AI will do, and again, this has to be done properly, but AI, the way I see it, is that they're talking about collaboration. Again, we talked about a lot of collaboration. Collaboration among the computer scientists, AI experts, but also psychiatrists, psychologists, nurses, social workers, philosophers, ethicists. All of them need to work together. Every one of those areas needs to work together to find out how we can develop something with AI that is useful. We don't have a choice but to go to AI. Honestly, I mean, if we say that AI is not for us, we won't do that. That's the worst thing we could do to ourselves and our patient. There's no choice there. So where we have to get in is not accept the AI as they say, but we need to understand that, work with those AI experts, make them realize that this could be used badly for people with mental illnesses or older people. Let us be
True.
careful. And things are happening in Japan, for example. There are lots of older people, more than another. Use of robots is very common by older people in Japan. These
Right.
are robots who actually help them get healthcare and so on and so forth. So again, my strong sense is that let us not ignore AI or say it is not. We must learn about AI and try to see how we can make it useful for our clientele.
Definitely. So we'll go the Buddha's way. We'll practice middle path and practice caution, but at the same time, build on the strengths of the AI. Okay, the last question to you, sir. Given your leadership in global editorial and psychotherapy networks, what strategies can amplify the visibility of culturally grounded mental health interventions from underrepresented regions like South Asia and Sub-Saharan Africa?
Again, great point, great point. And this is really important to have. Again, honestly, that's why I compliment the Global Health Forum, because this is what is needed. We need to really look at different cultures and bring together people. So there is mutual communication, because just like we are talking about that, surely the low income countries can learn from high income countries, but high income countries can learn from low income countries too. So the way things are getting done. So what is needed is this kind of collaboration, and also collaboration among different areas, not just healthcare, not just psychiatry and oncology and no, also healthcare economics is critical. Epidemiology is critical. Computer sciences is critical. We have to do that. We have no choice. Uh, the good news is that it can happen. I think it is sometimes if you just think about what is need to happen, you will say, "Oh my goodness, that will never be able to do that." It's so no, it is possible because there are examples, role models of things that are happening. So, and we need to take a look at those role models. I think often what happens, we look at the negative side. We look at suicides and drug abuse. We should also look at societies that are happier, that they do well, they work together. Where, as I said, this robots in Japan, older people like those. They love them, honestly. There are a number of papers that have been written on them. That doesn't mean they're perfect and they will apply it. But let us look at these positive models. We need positive thinking. And that's why my whole focus of positive psychiatry. Don't just think about illnesses, disabilities, downsides. Let us think about the positive side. Everything has a positive side. In schizophrenia, for example, actually my focus of research was not what causes and risk factors, who recovers from schizophrenia. What are the positive factors that lead to? There's a movie, Beautiful Mind, story of a Nobel laureate who had schizophrenia, who improved, and so on. Let us look at those. Why is it that there is recovery rate is higher when that time in India than it is in the US? So coming back, let us look at the whole things, but especially the positive models. That is critical for us.
Right. So, thank you so much, sir. Such an illuminating session. I know you're tired responding to my fire of questions. I've been asking questions. I've been a little insensitive in framing so many questions, but I wanted to unpack and literally gather every wisdom that you have and all the experience. Because our participants who are still here after 3 hours of the session, 3.5 hours, 257 people are still live, on Zoom itself, and they're sending lots of love emojis and beautiful emojis in praise of you. That shows the level of enthusiasm people have. They have interest, and they're actually doing this. So thank you so much. Okay, participants, your attendance link has been dropped in the chat, so please don't ask when it is going to be dropped. It is already shared, so please go and fill the attendance form if you want to get your certificate of participation. In the meantime,
you can also
yes,
pass my email to people so they can feel free to write to me. And just I also want to quickly mention, I have participated in a number of international seminars, etc. I haven't seen one like this, which was 3.5 hours, and there are still 254 people. That's really, it's one of the positive models I will talk about. So thank you and congratulations and compliments.
Thank you so much. We'll allow one attendee to come and ask the question. So Faisal, please enable Jitendra Kumar Sinha to come and ask the question directly to Dr. Professor Dilip Jaste. Yes, Jitendra, go ahead. Do you want to ask questions? You have raised hand. Please be quick. Otherwise, we will go to the other candidate. Okay, I think he's experiencing some issues. So we'll go to Shita. Shita, you want to ask questions? Please go ahead.
Professor Dilip, for the wonderful presentation. I'm speaking from Nigeria.
Yes, please go ahead. We can't hear you.
Can you hear me, Prof?
Can you speak?
My question is a simple one. I just
okay.
I want you to elaborate on years and years to age. That's all. The concept of adding age to years and years to age.
Okay, the first quote, sir.
Thank you very much.
Adding age to years and years to age. The first quote that you said suggests. So he is asking about that.
I'm sorry, can you repeat the question?
Yeah,
yes, I'm asking about the concept.
Yes, can you please repeat it, Sita? Because your voice wasn't audible very properly.
Okay.
Can it be put on chat or which I can read?
Yeah. No, he is basically wanting you to expand upon the concept of adding age to years and years to age.
Exactly.
Like the first, the first quote that you showed in the first slide.
Yes, exactly.
There was one quote, yeah, means making life more meaningful and adding more grace to, aging gracefully. Basically, that was the quote about. So,
Yeah.
being productive members of the society and being engaged.
Right. Yeah, this concept is actually pretty old, from Aristotle's time. I mean, he talked about what we call eudaimonic well-being, which means having purpose in life and being happy. And this is something for older people really becomes important. And I showed that slide where older people are actually happier. They have greater well-being, less stressed out than younger ones. Why? One of the reasons is purpose in life. And so even when they have retired or they are having some cognitive problem, they feel good about themselves, that they're doing something, they're helping others, and others are helping them. So both ways, they feel good. And I think that is probably what is needed. And that is something which is needed universally. It is not just one culture, another culture. But purpose in life, which is meaningful, makes you feel good. And so that's really an important basic concept with that.
Yes. Okay. I think we had a great round of questions and everything. Thank you so much, participants, for all the questions you have put. I will just do one thing. I'll compile all the questions for both Professor Dilip Jeste and as well as for Dr. Lakshmi in two different Word files, and I'll forward it to professors, and they will respond to them whenever they are free, and we'll share it across all the groups that we have. We have WhatsApp groups right now, two groups. About 2,000 people, and then there is another group about 500 plus people. So we have like a huge collection of people who have been registering. So far, I would like to appreciate you, sir, that since the beginning of this workshop series in just 2 months' time, today we completed 2 months. And in just past 60 days, we have had 2,300 registrants for this particular program only, International Workshop Series. And our Global Advanced Certification Program was registered with 870 participants. 250 plus participants are research active. That means they are working on individual projects as well as group projects. And this program is completely running for free without any funding support from any source. And we are not charging a single rupee or dollar or any currency to any participant. It is completely an act of labor of love. It's offered completely for free because we want to invest in our younger generation. We want to help and hold them, support them, and mentor them. Things which I did not get when I was growing old. So we want to just do it for our younger generation. So with this aim, we were doing this. So starting today, you are also their teacher, sir. You are one of our resource persons. So far, we have invited 19, as on today, 19 resource persons from 6 different countries and 4 different continents. So you are one among them, but by no means in any way, I think you are the cherry on the top, like in my opinion, because you are the very best that I have got on our platform so far. I'm extremely proud and very, very honored and by your presence, sir. And all that I want to say is I'm indebted to you for your presence and for sharing all the wisdom and experience that you did. I look forward to having you on the board of Global Health Forum and Global Consortium, sir, and support us and hold us and mentor us so that we perform better. We deliver the values with which the mission with which we have started. It's a very, very humble and very noble effort, sir. So please support us. We would be very indebted to you for this. And our admin team would be in touch with you for your e-signature, which will be printed on the certificate for all the successful participants coming out of the Global Advanced Certification Program. And in addition, we would be also requesting for the resource materials, including the slides that you use for your presentation, sir, if you would like to share with the participant. Many of them request for those, so we would really appreciate that. And with this, I want to express my heartfelt gratitude to you, and it is my immense pleasure to have you, but also I understand that it's a very early morning in US and you took all the pain to stay for almost more than 3.5 hours now with us, and you have been here with us and you have been very, very candid, kind in supporting us and in responding to all my questions very gracefully. I think I could not have expected anything better. I think my days, I'm very lucky, I'm very privileged This is all God Almighty. So I look forward to the opportunity to talk to you more, sir, in the future and have you on our board so that we do better things together. So with this, my duty gets over. Faisal, please do the dues.
Thank you, Professor Dr. Dilip Jeste, and our moderator, Professor Maheshwar Satpathy sir, for delivering such deeply meaningful sessions that advance critical conversations around mental health, aging, and systems equity. So to all our participants, your attention, questions, and commitment fuel this movement. Let us continue to advocate for research, policy, and care that places people at the heart of systems transformations. We look forward to seeing you in session 10. Until then, stay curious, stay hopeful, and good night, everyone. And thank you, Dilip Jeste sir, for such a wonderful session.
Thank you. Thank you. Yes.
Thank you, sir. Yes, sir. Sir, we shall be in touch with you personally over chat later. Thank you. Okay, participants, your attendance form has been shared in the chat. Please fill it properly and do not commit mistakes in filling your name or your email ID is correct. We noticed many mistakes in the past feedback form. Many email IDs were filled incorrectly, due to which some of you did not receive your certificates, although the certificates were ready. Okay, so please do not commit the same mistake this time. Please fill the form very carefully, at least your name and your email IDs, okay, because we don't want to deprive anyone of their certificates. We are very ethically run organization. We give certificates to everyone, and don't please send me messages, personal message saying when am I getting the certificate. Your certificates will reach you in 7 days, 5 working days, 7 days in all total. Okay, so if today is the session, you will receive it by next Sunday. Okay, coming Sunday, that means. Okay, so that's all from our side. Have a wonderful Sunday night and eat and sleep well. Take care of yourself, remain productive, remain inspired, keep engaging yourself with the global society, keep contributing to the world. We are here